with us. We ran a little long this morning. We wanted to give the commissioners a moment to get a bite, and I wanted to hold off a moment so that our good presentations could be heard by all the commissioners as opposed to starting with just a few folks in the room. So thank you for your patience. I'm Bruce Chernoff. I am the chair of the Long-Term Care Commission, and on behalf of all of the commissioners, I want to thank you for being here today. We look forward to two really wonderful panels. I want to be clear about what the ground rules are for today. So it's 10 minutes for each speaker. We ask you to really hold to 10 minutes. There is a clock that has the time there. And actually, if our speakers would take their seats, that would be great. For commissioners, the rules of the game are 5 minutes of questions. We're going to hold you to 5 minutes of questions so that we can get through all commissioners and hear a full range of views. With that, I want to turn to my vice chair to see if he has anything he'd like to add before we begin.
Just to thank all the attendees and in particular the members of the panel for on relatively short notice to come and share your experience and knowledge.
With that, we'd like to begin with our first panel. Today we're going to be looking at service delivery and provider innovations and kind of a related set of issues. And we have four really wonderful speakers. We thank you for being here. Let me begin by asking Eric Berger from the Partnership for Quality Home Healthcare to begin.
Thank you very much. Mr. Chairman, members of the Commission, I appreciate the opportunity to present our views to you today. My name is Eric Berger. I serve as CEO of the Partnership for Quality Home Healthcare. We're a coalition of more than 2,000 freestanding and hospital-based home healthcare agencies across the country. We're committed to advancing innovative reforms, and therefore very grateful for the work that you're doing and hope that the comments we wish to share with you today are of value to your work. As you, of course, know, the demographic and long-term care challenges facing the country are daunting. We believe a broad array of strategies are needed to meet this challenge. We believe healthcare at home can play an integral role. We likewise believe that certain public policy changes could also have a significant and a positive effect. We do want to note that we don't believe that those changes need to be radical in nature. In fact, we think that thoughtful evolutionary reform can do much to achieve a stronger long-term care infrastructure in this country. First, though, I'd like to make a few comments about the extent of the challenge facing our nation. You know better than anyone that the demographic trends we're experiencing are unprecedented, with nearly 1 in 5 Americans projected to be over the age of 65 by 2030. We're facing a truly daunting challenge. In addition to its sheer size, our senior population is also projected to be increasingly frail. This chart is from an Urban Institute report. It indicates that frail elderly, as a percent of the non-elderly population, will rise by 65% by 2040. Further, the fact that a majority, or 70% of seniors, are projected to need some form of long-term care underscores the importance of crafting an innovative and a sustainable solution. Healthcare at home is ready to serve as a resource for America's frail elderly. Home health agencies deliver clinical and social services to millions of America's most frail and vulnerable seniors every single day. For example, home health agencies serve nearly 3.5 million seniors and disabled Americans who are so infirm as to meet the qualification criteria of homebound. This population is documented as being older, sicker, and poorer than the Medicare beneficiary population as a whole. Just as important, home-based care is what the majority of elderly consumers want. ARP documents that 9 out of 10 seniors prefer to remain in the dignity and comfort of their own home, where they can remain independent and close to family and community supports. Within government programs, there's already strong recognition of the clinical, human, and fiscal value of healthcare at home. For example, state Medicaid programs are leaders in expanding access to home and community-based care. It's impossible to cite any single state as the leader in this regard because so many are working on this front. But I do want to quote Governor John Kasich of Ohio, where the Passport program has been given quite a bit of attention. Quote, "In the past, if somebody wanted to stay in their home, there were limited opportunities for them to do so. That day is gone. I can't think of anything more important to a senior than to be able to stay in their home with assistance. The Department of Veterans Affairs is another long-recognized leader in this regard. Its home-based primary care program has documented 40 years of success in improving outcomes, achieving improved patient satisfaction, and reducing costs by as much as a net 20%. The VA's home-based primary care program achieves this through the use of interdisciplinary teams, care coordination, advanced technologies like telehealth, and the removal of barriers that had previously prevented veterans from being able to access care in their home. And of course, finally, there's Medicare, which has long been leveraging the value of healthcare at home through its home health benefit, in which nearly 3.5 million Americans participate today. As it relates to Medicare, and taking nothing away but from the prominent role that it plays, it is overestimated as a source of financing for long-term care. It's not the mission of the program, and it's not really structured to accomplish that. It is critically important, but we believe that it needs to evolve in order to be able to serve as a solid foundation for the future needs of an aging America. Innovative bundling and care coordination models are being explored today, and we believe they chart a course that is worthy of the Commission's consideration. For example, and in particular, we believe that site-neutral bundling can be a promising direction that can align consumer choice with improved access, efficiency, coordination, and innovation. Recently, the chairs and the ranking members of the Senate Finance and House Ways and Means Committees requested input from stakeholders about ways to improve the quality, efficiency, and coordination within post-acute care. The partnership submitted our comments yesterday, and I believe those comments have been distributed to you all as part of our resources. In short, we believe that site-neutral bundling can ensure the delivery of clinically appropriate, cost-effective care in a manner that the program currently is unable to accomplish. As we envision it, such reform would include a number of key criteria which are summarized in the slide. We do believe that it would encompass all post-acute care settings, including outpatient therapy, that would provide for a single site-neutral payment for each specific clinical condition, that would allow for incentives for efficiency and coordination, who would utilize uniform quality measures to improve outcomes and transparency. It would provide for coverage of advanced technologies like telehealth. And it would importantly include a cost control mechanism to ensure that savings are achieved both for the program's own sustainability and potentially for the support of long-term care. I'd be happy during the question period, if you wish, to expand upon the views that we submitted to the committees. But in short, we believe that site-neutral bundling can both strengthen Medicare as a foundation for long-term care in America and also achieve billions in savings, again, both for the program itself and for a comprehensive long-term care solution. To fully realize this potential, we believe, however, that certain reforms and limitations also need to be considered. These include the removal of barriers to innovation, rejection of additional cost burdens upon beneficiaries, and the advancement of program integrity. Barriers to innovation include regulations that frankly impose cost without achieving value. It includes a lack of reimbursement for advanced technology and the inability of many home health care providers to be able to leverage other resources in order to deliver the best possible care outside the confines of the current benefit. Similarly, with beneficiary cost burdens, we're aware that some are considering the reimposition of a home health copayment or uniform cost sharing within Medicare. There is ample evidence to suggest that higher out-of-pocket costs are particularly burdensome on the low-income beneficiaries who tend to utilize the Medicare home health care benefit, and as a result will shift them into more costly settings, which will also mean higher costs not only to the federal government but to state governments as well. Congress repealed the home health care copayment in 1972, and it did so, I quote, because it found a financial burden on many elderly persons living on marginal incomes. We therefore agree with governors, Republican and Democratic alike, policy experts including former CBO Director Douglas Holtz-Eakin, and advocacy groups such as ARP that such a direction is the wrong one to take. Instead, we believe that program integrity reform that targets the isolated instances of persistent abuse within the Medicare program is essential, and it will provide greater confidence not only to regulators and taxpayers, but beneficiaries and the vast majority of ethical providers. Finally, we believe that this direction will also help to further expand a workforce that is already growing to meet seniors' needs. According to the Bureau of Labor Statistics, the home health sector is a leading creator of new jobs. In fact, looking just at the July report, which BLS just issued, the healthcare sector as a whole would have posted a net reduction in jobs were it not for the thousands of new jobs created in the home health sector. The expansion of the home health workforce should come as no surprise, of course. It's due to consumers' preference as well as payers' selection of home health as a cost-effective option. And its growth will continue and therefore serve as a strong foundation for long-term care with evolutionary reform like site-neutral bundling, the correction of obstacles to care, stable funding and dedicated training, and the support for family caregivers who play such an integral role. In closing, on behalf of the partnership, I want to express our optimism about the work that you're undertaking here and about a future in which consumers' preferences will be aligned with improved access, outcomes, care coordination, and efficiency. Thank you very much for your time. I hope our perspective is of value to your work, and we stand ready to be of any assistance we possibly can.
Thank you very much. Next, we'll hear from Lisa Alecxih from the Lewin Center for Aging and Disability Policy.
Good afternoon. Thank you for having me. I approach this as a researcher and a member of an organization that supports implementers of new and innovative programs, and so I'm going to take a broad view on this. I get the opportunity to work with a number of federal agencies, including the Administration for Community Living, CMS, the VA, ASPE, HUD, state governments, and then local organizations, community-based organizations, hospitals, and local health systems, and that's the perspective I bring to this. So there's 4 areas of innovation and best practice I want to cover, and they include the encouragement of informed choices, the support of unpaid caregivers, the deployment of technology to improve communication and coordination, and finally, integrating long-term services and supports with primary, acute, and behavioral health care systems. We can't leave this as the silo. We need to really think about how to bring it all together. Under informed choices, what people need when they're trying to think about what they're doing in terms of long-term services and supports, whether that is when they're younger and they're trying to plan for the future and be prepared financially, or when they're actually in a crisis and need those supports immediately, they need an infrastructure that can provide them the information that they need and help them make the decisions that they need to make. And that infrastructure is there to a degree, but it's very under-supported. There is a system of aging and disability resource centers that covers over 70% of the population in this country now, and it's being supported by CMS, it's being supported by ACL, and it's being supported by the VA. And it's a way to gain access to publicly funded programs if you're eligible for those, but also to gain access to private, if you have private resources to bring to the table, to gain access to services in the community. And so it goes beyond any one program, and it serves all people with all payer sources, and it also from all populations. It's not perfect. It has a lot of ways to go. There are critics, but there are clear opportunity through building on these community organizations that are bringing together a number of organizations in any given community to provide a no wrong door and to provide some consistency and some information and supports and options counseling when people need them. It's also a system that can and does, and has recently through the Community Care Transitions Program, reach out to people at a critical juncture. So not only is it responding when people call in, but it's also going to people when they need it. And through the Community Care Transitions Program that's funded by Medicare, and it's a demonstration, these organizations are partnering with hospitals to be able to bring services and supports to people as they're discharged from the hospital or at high risk of readmission, and bring those community supports to them, make sure they understand their care, make sure that they understand what their next steps are, do MedRec in the home, which is absolutely critical. you don't know what's going on until you see the pillboxes that are in people's cabinets. These are critical things that happen in the home, and community-based organizations are helping with these, and Aging Disability Resource Centers are one of those organizations. The Minnesota Diversion Program I won't even go into because I know that the next speaker is going to cover that, but there's also efforts to intervene again at critical junctures where people are either leaving a hospital or are newly entered into a nursing home, to provide them options so that they understand this might be just a post-acute care stay. There are options to receive care back at home. You don't have to stay here if that's not your choice, or if it's not an appropriate place for you to be. So I'll let the next speaker deal with that one. Options, I talked about options counseling a little bit. It's a person-centered approach to decision-making. It's a discipline. There's a training being developed for options counselor by the Administration for Community Living right now that'll be rolled out nationally. It's a discipline that is important because it takes that person's perspective, their goals, and the way they want to approach what needs to happen. And so that's critical for making sure good decisions are made. And then the streamlined access to public programs is, making it just as easy to get to the home and community-based programs as it is to get into a nursing facility. And finally, for those who do have their own resources, making sure they understand what is available to them and making those connections for them. On the issue of supporting caregivers, I'm sure you all have heard and are very well aware that 2/3 of the care that are provided to people in the community are from unpaid family and friends. And that is a critical resource that we need to support, because if we're not supporting it, it's going to fail, and that's when you end up with people in more expensive settings than they actually need to be. And if a little bit of support in the community for these folks who are dealing with increasingly complex needs, health needs, and providing health care, actually medical tasks, documented by AARP. They often serve as the de facto care manager with very little information and knowledge in order to do that, and they don't even recognize themselves as caregivers. And in supporting caregivers, it needs to be more than respite. Respite is a very useful benefit that gives, brief relief to folks who are caring for others, but they do need that information, they need that education, and they need those out-of-the-box supports. So if you're on a horse farm and the horses need taking care of for a little while, that might be something that needs to happen in order to make that sure that caregiver is able to continue caring for the person who needs supports. There are limited supports available for caregivers. The Older Americans Act has about $160 million annually that supports caregivers, primarily of those over age 60, but also grandparents caring for grandchildren. The new VA Caregiver program, again, another panelist will probably take that one on, but that has had a fairly large appropriation over 4 years of $1.5 billion, and that's providing stipends for caregivers of veterans of post-9/11 wars. There's state-funded programs that are available for caregivers, and then some of the programs that support individuals with disabilities will pay families and friends to provide care. Some of the Medicaid programs will allow this. There's state-funded programs who allow this, and also the Veterans Directed Home and Community-Based Services Program allows this. The third area is deploying technology. And technology, if we apply it correctly and well, holds so much promise. It can provide information when needed through the Aging and Disability Resource Centers. There are resource databases where people can look up what's available in their community in order to find what they need. Worker and housing registries if you're trying to hire a worker on your own. Decision support. There are software programs that will kind of take you through a decision, find out what your needs are, and make recommendations. It also can be used to improve coordination and avoid duplication. There's electronic referrals. If somebody comes in and asks, is in need of something, being able to transfer that information electronically to another organization that might deliver it. Warm handoffs through advanced phone technology, so when somebody calls one organization and actually a different organization could help them, they can just kind of transfer them very seamlessly. And including long-term services and supports providers and personal health records in the electronic health record of the medical system, because the information that's provided in those settings, these are the people who see people every day. These are the people who can notice things, and this information both going both ways, from the health system and to the long-term services and supports providers, is critical. And finally, technology can allow independence through communication and monitoring. There are home monitoring tools. You can do video visits remotely. There's even an organization in Richmond who has something called Granny Pods. They'll plop it in your backyard. It's got all the bells and whistles for monitoring, and you can have your loved one live in your side yard very comfortably. So the last area in my remaining minute here, the integration with healthcare. So these next two slides sort of emphasize the importance of this group. What you see along the continuum there is that as you have chronic conditions and functional limitations, as the number of functional limitations increases, your likelihood of being in the top 5% of spenders for healthcare and long-term services and supports is 4 to 7 times the, sort of the general average. So this is for all ages and all populations for people living in the community. The next slide shows that individuals with functional and cognitive impairments are an important touchstone for systems transformation, and it goes beyond those who are Medicare and Medicaid duals. Because those who are Medicare only, who have functional limitations, look an awful lot like those who are Medicare and Medicaid and have functional limitations. So those in nursing facilities, those who are in the community with ADLs and IDLs. So it's an important marker for someone who may need additional supports that the healthcare system doesn't even recognize. You only get a function, an assessment for functional limitation if you're going into a nursing facility or you're receiving Medicare home health. There are a lot of other people out there who have functional limitations who can benefit from additional supports that we don't even recognize within the healthcare system, and there needs to be a way to do that. And so finally, community integrated systems need to be patient and population and community centered. Healthcare is local, so is long-term services and supports, and that's where most of it is happening and needs to be anchored. It needs to go beyond just long-term services and supports or healthcare and include behavioral health and the whole continuum. The idea of the right services at the right time in the right setting, using evidence-based interventions that have been proven to have good outcomes, and then including the users of long-term services and supports and their caregivers, both the paid and unpaid, in a role in this system across both health and long-term services and supports. So thank you for your time.
Thank you very much. Next, we'll hear from Loren Colman, who is from the Minnesota Department of Human Services Continuing Care Administration.
Thank you, Mr. Chair and members of the Commission. I am the Assistant Commissioner at the Department of Human Services in Minnesota. It's an honor to be invited to present today. My administration plans for and administers the publicly funded long-term service and support system in Minnesota, with the divisions that serve persons with disabilities, aging individuals, deaf and hard of hearing populations, and those in institutions. Today I've been asked to describe Minnesota's system of long-term services and supports, with special focus on how we are addressing the needed service delivery and provider innovations in light of the demographic realities and the challenging budget forecast that we all face. I know a lot of people say that Minnesota is different from other states when it comes to our approach to human services issues, and it's not snowing there yet. But on these topics, we really don't claim to have the answer. But we try different approaches, and we're not waiting for the perfect solution. What we do have a belief in is visionary incrementalism for our long-term services and supports. We have a long tradition of merging short-term needs with longer-range solutions. So, visionary incrementalism. We've worked for the past 25 years on incremental changes to achieve that long-term vision, was to reduce our reliance on institutional models and help people remain in or move to community settings. We have an administration and legislature that has been very supportive of our reforms that we brought to them for enactment. Our most recent reform package, called Reform 2020, was just approved this year, and we are still in discussions on the waivers and other approvals that we need from the federal government to implement the reforms. My longer written testimony provides much more detail regarding our system and the reforms that we have made or plan to make in the future. In my short time this afternoon, I will briefly describe several elements of our system, explain why it is important, and provide examples for how each element works to empower and assist older adults, persons with disabilities, and their families. We have a strategic plan. We use it to set goals and to determine outcomes. It doesn't sit on the shelf. It was developed through several working sessions over 18 months and included participation by our numerous stakeholders. The demographic realities are known to all. In Minnesota, we will see the dramatic growth in the population aged 55 to 75 in the next 10 years, similar to most states. Also note that the growth in the 75 plus, which is when most long-term care is needed, is also growing substantially. We also expect growth in our population with disabilities at all ages. Our budget forecasts are significant to us. Our long-term care program expenditures will increase from $3.2 billion in 2013 to $4.2 billion in 2017. And believe me, I need to explain that to our legislature each year as to how we are working to bend that curve. Because our forecast, though, only goes out 5 years, it does not include the impact of the aging boomers, whose long-term care needs will begin to affect our budgets after 2020. So let me describe several of our long-term services and supports changes. Providing information to empower people. Information is power, and we find that information helps people make better decisions and can often present a crisis later. A couple examples. Our linkage lines continue to expand and serve more people each year. The senior linkage line, the disability linkage line, our veterans linkage line. Our Disability Benefits 101, which provides essential information to persons with disabilities who want to work but still need their health and disability benefits. We are changing the expectations about employment for people with disabilities, and this is a significant tool to achieve that goal. Helping people when needs are low. On slide 8, we have a description of our current system. We are raising the eligibility bar for the traditional long-term care Medicaid services and creating another service package for those with lower needs that is outside of Medicaid. This old home and community-based system, where once you were eligible, you could access the entire service menu, is what we are modifying. Most people had access to the entire waiver system. Our new home community-based system, on slide 9, looks at your needs and makes the service packages you need available to you at the time you need them as people's needs change. So you can move from intensive supports to family supports based upon your changing circumstances. We are also moving to a uniform assessment tool for all populations called MinChoices. This does away with the inconsistencies and differences across our various waivers and the different assessment tools that each have used that have caused problems in the past. This is a web-based comprehensive assessment that is done with the program participant. Another important part of this element is support of family, informal caregivers, and fostering communities for a lifetime. We've actually calculated the value of family and informal network support at $3.5 billion a year in Minnesota alone. These are additional ways to help individuals with low needs use nearby networks to meet their needs and may prevent or delay their need for safety net programs. Let me talk about a couple specific initiatives that we have in Minnesota. Helping individuals remain in or move to the community. On slide 10, we have our housing access program, which is designed to help people who are in what is known as group homes or ICFDDs move to homes of their own. And you can see the growth in that program through the few short years that we've implemented the program. We're also redesigning our PCA services to make them more person-centered and help those receiving the service to become more independent. Again, we're in discussions with CMS about the Community First Services and Supports Program, and we hope to implement that in 2014. Because of dramatic growth in assisted living in Minnesota, another project is looking at replicating the package you receive in assisted living, but instead receive it in your own home at a more affordable price. We're calling it assisted living without walls, so that people don't have to move from their own home to receive the assurance of a bundled service in assisted living. Slide 10 shows the progress we're making in using, I'm sorry, we already talked about that one. Slide 11 shows what we're doing in helping people move from nursing facilities. These are community living specialists that identify individuals in nursing facilities that have not relocated on their own. Many people do, but there are a number of people who do not successfully transition back home. The note on this one is that these are private paying individuals. They are paying their own way, but they express an interest in moving home. And so our area agencies on aging are helping them achieve that vision. Slide 12 shows what we have achieved over the last number of years in reducing our reliance on institutional care. 25 years ago, we were one of the highest states using nursing facility beds. And today we are lower than the national average when you look at the 85 and over population. We currently also have a moratorium on ICF beds and corporate foster care homes. Again, we are trying to challenge the system to invent itself with other lower cost and more consumer-directed services. An example of an initiative to measure and report quality is shown on slide 13, our nursing home report card, one of the most comprehensive in the country, getting several thousand views per month. We now have the authority to design a comparable report card for home and community-based services in 2014. One of the elements that we're really tackling significantly is strengthening our protective services. As our services have changed over time, we believe that we need to redesign this, and it is the next big thing in long-term services and support. So, part of our Reform 2020 package did give us the authorization to redesign adult protection. We will have a single toll-free statewide telephone number to report any issues that are observed. We're going to create a public awareness campaign, and we provide additional funding to counties to provide the critical service of investigations. We have community service development grant funds. We do our work through partnerships, through our providers, consumers, advocacy groups, counties, health plans, area agencies, independent living centers, tribal organizations, and so on. We don't always agree, but we always discuss. So slide 15 shows what we refer to as venture capital, to challenge providers to invent new ways of supporting people. One of those areas that we're also proud of is Wisdom Steps, which is an initiative of our Board on Aging, encouraging tribal elders, especially on our reservations, to take simple steps towards better health. Looking to the future, we have our Own Your Future campaign, again, a public awareness campaign to help Minnesotans plan for the future. We're looking at long-term care products to fund those services, similar to what you're looking for. And then we're also going to be examining how Medicaid aligns with those various products in the marketplace. And last, but certainly not least, we are looking at a full-fledged effort to look at a larger vision encompassed in the Americans with Disabilities Act, surrounding full participation in our communities by people with disabilities, more consistent with the Olmsted vision, and making that available for all people with disabilities. Sorry for rushing through this, but that's why I gave you longer written testimony so you could see more of the detail. and I'll be happy to answer any questions during the question and answer period.
Thank you very much. And finally, we'd like to hear from Laura Taylor from the Department of Veterans Affairs, please.
Good afternoon, Chairman Chernoff, Vice Chairman Warchowski, and members of the Commission. Thank you for the opportunity to discuss the Department of Veterans Affairs efforts regarding the Caregiver Support Program, VA's resources for enhancing all caregivers' health for veterans, or REACH VA, initiative, and other VA services available to support family caregivers. VA recognizes the crucial role that family caregivers play in helping veterans recover from injury and illness and in the daily lives of veterans in the community. VA values the sacrifices caregivers make to help veterans remain at home. Caregivers are our care partners in the care of veterans, and VA is dedicated to providing them with the supports and services they need. The Caregivers and Veterans Omnibus Health Services Act of 2010, also referred to as the Caregiver Law, has allowed VA to provide unprecedented benefits to approved family caregivers of eligible veterans. After the law was enacted, VA established a comprehensive national caregiver support program with a prevention and wellness focus, which includes the use of evidence-based training and support services for family caregivers. The Caregiver Law establishes additional benefits and services for approved family caregivers of eligible veterans seriously injured in the line of duty on or after 9/11 under the Program of Comprehensive Assistance for Family Caregivers. Additional services and benefits include a stipend paid directly to the designated primary family caregiver, enrollment in VA's Civilian Health and Medical Program, or CHAMP VA, for the designated primary family caregiver if eligible, an expanded respite benefit, mental health treatment, and travel expenses for eligible family caregivers. Required family caregiver training is provided as part of the application process through VA's partnership with Easter Seals. The VA's Caregiver Support Program has been accepting applications for the Program of Comprehensive Assistance for Family Caregivers since May 9, 2011. As of September 30, 2012, there were over 6,600 participants in this program. Due to the large demand, VA obligated $95.6 million in fiscal year 12 to operate this program. VA offers a variety of additional services and resources to family caregivers of veterans from all eras. One valuable resource for caregivers is their local Caregiver Support Coordinator, or CSC. These individuals serve as the clinical experts on family caregiving issues and are experienced social workers, nurses, and psychologists. VA requires each medical center to employ at least one full-time position to serve as the Caregiver Support Coordinator. They provide support and programming to family caregivers, link caregivers to community and VA resources, and respond to referrals from the Caregiver Support Line. At the end of fiscal year 2012, VA funded 192 full-time caregiver support coordinators in the field, obligating $16.5 million to support the salaries and benefits of these crucial staff. Another important service VA established on February 1st of 2011 is the National Caregiver Support Line, which is staffed by licensed social workers. The support line is available to respond to inquiries about caregiver services, as well as serve as a resource and referral center for caregivers, veterans, and others seeking caregiver information. As of September 30, 2012, VA's Caregiver Support Line had received more than 52,000 calls. Approximately 3,200 callers had indicated the veteran care recipient had a diagnosis of Alzheimer's or other dementia. And of those callers, 44% indicated they were a son or daughter, and 33% indicated they were a spouse. VA obligated approximately $1.8 million to operate the National Support Line in fiscal year 2012. Another highly utilized resource that is VA's website dedicated to family caregivers, www.caregiver.va.gov. It provides caregiver stories, resources, and a zip code locator feature that allows caregivers to identify their local caregiver support coordinator. The site also has a listserv function which currently has more than 20,000 subscribers. VA obligated more than $220,000 in fiscal year 12 to support this valuable information resource. In addition, the Caregiver Support Program launched a peer support mentoring program in January of 2012 to decrease the isolation that many caregivers feel by providing a more formal support mechanism for social networking. The program matches seasoned caregivers with less experienced caregivers to receive guidance and to share their experiences, wisdom, and skills with one another. As of September 2012, more than 50 caregivers have participated in this program. Based on the Long-Term Care Commission's request, I would now like to go into more depth about the resources for enhancing all caregivers' health for veterans, otherwise known as REACH VA. REACH VA is a national program run out of the Memphis VA Caregiver Center located at the Memphis VA Medical Center. It is an evidence-based skills-building intervention, including individual sessions with an option for telephone support group meetings, designed to provide support, education, and skills building to eligible caregivers of veterans with Alzheimer's disease or other related dementias. While REACH VA began as a 12-session intervention, it is currently implemented in 4 core sessions, with the option for additional sessions based on caregiver need and clinician judgment. The intensive one-on-one intervention between an eligible caregiver and a VA clinician addresses 5 main caregiving risk areas, including safety, social and emotional support, problem solving, caregiver well-being, and both caregiver and veteran health. The intervention focuses on problem solving around behavioral topics, stress and coping techniques, as well as step-by-step strategies to assist caregivers in everyday problems they may encounter. In research on effectiveness, REACH caregivers show significant improvements in reported burden, depression, social support, healthcare behaviors, caregiving frustrations, and a number of reported behavioral problems. Family caregivers often spend time providing hands-on care, as well as spending time, quote, on duty, quote, which is defined as time spent providing supervision of the care recipient, time that cannot be spent relaxing, socializing, or doing other household or personal tasks. Caregivers who have participated in REACH report spending 1 hour less per day providing hands-on care and 2 hours less per day of, quote, on-duty time. The REACH VA intervention is grab and go with simple-to-use scripts, talking points, and a comprehensive caregiver notebook with 30 behavioral and 18 stress and coping topics written at a 5th grade level. Clinical staff at VA facilities are trained, certified, and provided with materials to deliver the REACH VA intervention by the Memphis VA Caregiver Center. The Veterans Health Administration and the Memphis VA Medical Center were selected for the prestigious 2008 Rosalind Carter Leadership in Caregiving Award for REACH VA. The award recognizes leadership in implementing innovative partnerships between community agencies and caregiving researchers that bridge the gap between science and practice. These partnerships help move effective caregiver support programs to widespread use in the community more quickly and efficiently. Through the end of fiscal year 12, clinical staff at 75 VA facilities across the country were trained in REACH VA. Additionally, at the end of fiscal year 12, REACH VA was adapted for use with caregivers of veterans experiencing spinal cord injury or disorder as a pilot program at 3 VA sites. The Memphis VA Caregiver Center also offers the Spouse Telephone Support Program, or STS. VA has long provided support in person and via telephone through the use of support groups to eligible family members and caregivers of veterans. In October 2011, Based on successful outcomes demonstrated by a Department of Defense research study, VA expanded support services by initiating STS. STS is designed to improve resilience, prepare spouses, significant others, and intimate partners to cope with reintegration difficulties, to serve as a support system, and to ease the post-deployment transition. At the end of fiscal year 2012, 63 VA sites had been trained in STS by the Memphis Caregiver Center. VA obligated more than $570,000 in fiscal year 12 to support the Memphis VA Caregiver Center, which provides training for both Reach VA and the Spouse Telephone Support Program. Finally, in February of this year, VA launched Building Better Caregivers, or BBC, in partnership with the National Council on Aging. BBC is an evidence-based, online, interactive 6-week workshop designed to help caregivers better problem solve and manage their emotions, stress, and physical health. More than 580 caregivers have signed up for BBC to date. Mr. Chairman, caregiving is truly a labor of love, and VA recognizes the crucial role that family caregivers play in helping veterans remain in the communities they defended, surrounded by those they love. VA is dedicated to promoting the health and well-being of family caregivers who care for our nation's veterans through education, resources, support, and services. Thank you for your support, and I'm prepared to respond to any questions you may have.
My thanks to the entire panel for a really excellent job. I'd like to begin to my far left with Commissioner Claypool, please.
Thank you, and thanks to the panel for preparing their testimony and on a quick turnaround and frankly joining us in our sprint to our kind of statutory deadline. First, Lisa, I just wanted to kind of pose a question to you. You've mentioned this Aging and Disability Resource Center infrastructure, in particular the options counseling portion. My question is really driving at a return on investment. I understand we've, as a nation, have invested some rather modest sums, and I'm uncertain as to, what annually has been allocated to this, to develop this infrastructure, and do we see real return on this investment that we're making?
The Affordable Care Act provided $10 million annually for 5 years for aging and disability resource centers and the infrastructure development. And I think the return on investment, so the Administration on Community Living has sort of tailored what they've done. There was a broader reach for all 50 states in the first 2 years of the $10 million each. And then this year and last year they narrowed down to 8 states and really giving those 8 states a greater amount of money to work with and try to implement really major systems transformation. And so I think the verdict is still a little bit out. I think it's incredible, though, that over a 10-year period since they started, that now 70% of the nation has an organization or group of organizations within every community that are striving to do those functions.
And so it's my understanding that where an options counseling function is operating at, say, a higher level in those states, that we may be seeing individuals making choices about getting their long-term care needs, which avoid things like institutionalization or even Medicaid eligibility. Is that accurate?
Yeah, it's not causality, but we were able to, so in our technical assistance to the Aging and Disability Resource Centers, we have rated each state in terms of how well they're implementing against what we call a fully functioning criteria. And it has a scale, has 30 different items, can get a 2, a 1, or a 0. Basically you're doing well, you need some work, or you're not really addressing the issue. And so it's a 0 to 60 scale. And if you plot that against the decline in the Medicaid census for nursing facility, there's a fairly strong correlation. So like I said, I can't prove causality, but states that are focused on this, they're probably focused on other things also, but states who are focusing on this are doing well.
So really a modest investment in an infrastructure that's necessary, is not trying to put words in your mouth, but that
Doing a good
is-
job.
we're moving towards a place where we could actually demonstrate that this is really a cost-effective.
Yeah, and there's an evaluation going on by the Administration of Community Living currently on the program, so maybe there'll be more information from that shortly.
But there is no new money for ADRC.
There are no money, no.
And again, the modest investment of $10 million a year was,
And it's pretty small. And it pretty much, it's not providing services, it's not paying a lot of people's salaries, it's basically dealing with infrastructure and development and.
sure. And then quickly turning to Mr. Colman from Minnesota, thank you for joining us. It's my understanding in your proposal that's before CMS is that you actually are, and please correct me, I may be way off here, in investing your Medicaid dollars to help individuals actually before they become eligible for Medicaid, so that there might be a benefit that you would extend to an individual that might allow them to get some of the supports they need without actually becoming eligible for the program?
Thank you for the question. We have had discussions with CMS, and we're fairly a long way down the road, and I believe we will come to an agreement where we will receive some federal participation for pre-Medicaid eligible individuals. In other words, people who are living at home, currently receiving state support, that we are able to demonstrate by the support we're providing keeps them from needing to apply for Medicaid, and therefore saves the federal government dollars and saves the state government dollars. We refer to it as our alternative care program, and it's a long-standing program that we believe has been a significant tool. It's small, but significant to those people who are participating.
So again, just in closing, you're actually making investments that help individuals stay in their home and in some cases actually avoid their reliance on a program like Medicaid.
That would be correct.
Commissioner Stein.
I echo my colleagues' thanks. I learned so much from the four of you. Mr. Berger, you talked about the need for Medicare to evolve, and with regard to the home health benefit, do you have recommendations that would help people stay at home who are qualified currently for Medicare, enrolled in Medicare?
Our view is that the access to home-based care is too limited now in Medicare, given the advances in healthcare at home, technology, caregiving, and the like. That's by design. As you know, of course, the home health benefit is specifically for those individuals who are in need of intermittent skilled nursing services or therapy services and are deemed by their physicians to be homebound. Part of our focus on site-neutral bundling is that it would eliminate the silos that currently populate the post-acute care space. We could go into that in more detail if you're interested, but specifically to your question, that then would also gain access to home-based care for people who today wouldn't qualify, typically because of the homebound restriction.
So would you therefore suggest that the confined to home standard be altered?
Under a site-neutral bundle, it would no longer be applicable. So that if, for example, a patient discharged for a knee replacement surgery under MSDRG 470, who just can't wait to get back to her doubles partners in the tennis court, she can't now access the care that she's needing in the home, she's clearly not homebound. But that would be the most cost-effective place in which to serve her. A site-neutral payment system would allow for the patient to be able to be served in any number of different settings, not just a particular one.
Okay, thank you very much. And I wondered, with regard to the VA programs, which are so wonderful in terms of the the varied supports for family and friend caregivers. Have others approached you to, do you have notions of whether these could be fungible for people who aren't veterans, and for people who have the same kinds of functional limitations or cognitive impairments who weren't veterans, and has there been discussion of that?
So certainly the REACH VA program that I mentioned is currently being implemented outside of VA in a couple different states, I believe. And so that is an intervention that has, 20 years of research behind it and has evolved, that VA has been able to implement. It isn't necessarily something that we, created or whatnot. So that's definitely one that I would highlight to answer your question.
And thank you very much. And Mr. Colman, I'm going to go back to Mr. Claypool's question because I didn't understand the answer. With regard to the pre-Medicaid population, as you probably can tell, we're asking about things that we've discussed and we're trying to get more clarity on, so that's great. Mm-hmm. You said that there are people who are receiving some state support. Is that right, but not yet Medicaid? And if so, what would that be?
That is correct. They're receiving supports to remain in their home. Could be homemaker services, it could be chore services, it could be home modifications, variety of services, but they have not spent down to Medicaid eligibility
So are they,
yet.
the only reason I'm interrupting is because I have a minute and 8 seconds. Is the state paying for those services in some other way that just is Minnesota-based?
Currently, right now, the state of Minnesota is funding this program.
I see. Okay. Outside of the Medicaid program.
Correct.
Some other wonderful thing that I'd like to know about in another time. Thank you so much. And Laura Taylor, also, you talked about required training for those who are providing supports to the family caregivers. And can you just give me briefly a notion of what that kind of training would entail?
Sure. So as part of the comprehensive assistance program that we offer, there is a required training, a core curriculum, and I have also called it something like Caregiver 101. So it's the basics of caregiving, a core curriculum that is required in order for caregivers to be paid the stipend and to become eligible as part of that program of comprehensive assistance.
Well, thank you all so much. I've learned a lot. Thank you.
Thank you all very much, not only for your excellent testimony, but for what I know was producing it in a very tight time frame. Thank you very much. Mr. Berger, first, you mentioned in your very helpful testimony, particularly about talking about policy implications, and you alluded to barriers to innovation, and particularly regulatory limits in scope. I know you've talked about the need for bundling of services, but I wonder if you could help us, inform us about particular policy recommendations that we might make as a commission that would help facilitate and really expedite the kinds of vision and the kind of person-centered care that you described.
Sure, happy to. Thanks very much for the question. There are several in particular that are probably most in focus right now by the administration, by members of Congress, and by advocates out there. One, for example, is a face-to-face requirement in the Affordable Care Act, which has a very important purpose to it, and that's to ensure that the care that is being provided, this is, of course, within the Medicare home health benefit, has been ordered by the physician and is required. The difficulty is with implementation. We're seeing now that the community physician who has received the handoff from the hospitalist doesn't have the pre-existing experience, having not been that hospital-based physician, therefore was not the ordering physician, and yet needs to document the reasons that the home health care service was ordered. So there's an information gap. This is required by Medicare to be filled by the physician. The home health agency, which received that handoff, received that patient, cannot assist the physician in doing so. So the physician, being very pressed for time, is finding this to be an impossible task. information is not being filled out to carrier satisfaction, claims are being denied. We're seeing a number of different organizations out there, including the Center for Medicare Advocacy and others, citing instances of access being interrupted. And this is a case where a very laudable purpose is kind of being stymied by a fairly restrictive regulatory implementation path. A bit of a broader issue is just that the nature of the benefit is such that in the Medicare home health care space currently, a provider cannot contract with other service providers to be able to deliver into the home services that would best enable the beneficiary to avoid hospitalization, to avoid medical complications and the like, because they're not fitting within the confines of the benefit. So there are interventions that we know would be effective, they just cannot be leveraged.
Thank you very much. I'll follow up with more detail on that from you. And Mr. Colman, thank you very much for your description of a very visionary program that you have in Minnesota. It's a similar question for you. Clearly, you have done a lot in being able to provide care that is appropriate to the person, really respecting state resources and, in fact, investing state resources in a way that can really advantage patients. And clearly, there must have been a lot of Medicaid waivers in order to be able to get to the kind of systems that you have created. I wonder what policy recommendations you would have for us on things that we might suggest that would further enhance, make it even further allow you to streamline these programs.
Thank you for the question. I'll comment on a couple elements of the current system that I think are challenges in trying to move to an expectation that home and community-based services is the first choice. And you've heard this before. The fact that under the waivers we are not allowed to use Medicaid funds for housing or for food creates a pressure on the state to be able to have to fund those critical elements of living in the community. That is a barrier for oftentimes financially, whereas in an institution it's expected that the shelter and food will be provided. I think the waiver process itself could be streamlined. I'm not an expert in those negotiations, but it is really frustrating when you have an idea, you want to run with it, and because everybody's doing their jobs, it takes forever to get to the point to being able to try different things, even if they're not perfect, like I say, but to try certain approaches to helping people in the community.
I add my thanks to everybody else's and appreciate all your very valuable testimony and the work you all do. Mr. Berger, I wanted to start with you. I'm really quite interested in payment reforms for post-acute care services, so I'm glad you've raised the topic, and I'm sure that you are aware that the Institute of Medicine analysis has demonstrated that about 40% of the geographic variation in Medicare spending is attributable to variation in post-acute services, and they highlight particular issues with payment for home health care. And I'm interested in a shared savings approach because I think it reduces some of the incentives for skimping on patient care or selecting low-cost patients that we see going on in the post-acute world in all kinds of providers. And I wondered how you'd feel about applying that shared savings approach to existing rates, given that there's tremendous variability in profits, very high profits for home health agencies, and it seems we're all looking for ways to spend less and get better quality of care. It's an area that I think offers great potential in that regard.
Thanks both for the question and for your materials. We actually use a lot of your materials as we were working on our policy. So I hope that doesn't mean you now share the blame for what I presented. I do want to address the two aspects of your question, if time allows. First, as relates to shared savings.
But quickly,
Very quickly.
I talk fast like Judy, but I need you to, too.
Yes, ma'am. The shared savings and risk model, we believe, would absolutely apply here. Our vision is that there would be a risk-bearing convener, and so variability in spending would be something that the convener would ultimately own if, in fact, they were not able to manage the distribution in the most efficient manner.
But I'm thinking if you move to a bundled arrangement about that, I'm interested in how you're going to deal with the fact that existing rates may be dramatically out of whack in setting the overall bundle rate. And I'm also interested, as we experiment with bundles, in changing the way we're paying currently under the traditional Medicare system.
We wrestled with that. Ours is clearly by no means the perfect solution. As you might see in our letter, we actually recommend, for purposes of the ease of implementation, that existing fee-for-service codes be utilized. That may be something that is appropriate for the near term, as we then get into contracted rates over the long term. But thinking about going through a contracted rate process all across the board, or even just in a micro model, let's say hips and knees, seemed to us to be a fairly daunting task.
Okay.
So we propose that.
All right. Thanks, I appreciate it. And on site neutrality, are you distinguishing between capital payments and patient care payments in terms of creating a similar rate for different kinds of providers?
No, we don't
You're
make
not.
that distinction at all.
Okay, which
It's
seems
on a clinical-
problematic to me.
It's on a clinical condition-specific basis.
Okay, that seems, I would just note that seems problematic. Second, Lisa, I was excited to see your chart showing how much Medicare spends per capita on people with functional impairments. I think that we share a concern that there's so much focus on the chronically ill, but it's really chronic conditions plus functional impairments that are creating high costs, high medical costs. Right. And I believe you know that I, with colleagues, have proposed a Medicare initiative that the Innovation Center would look at to actually focus some of their delivery innovations on the functionally impaired and coordinate their long-term supports and services along with their healthcare services and apply well beyond duals. The dual, as you demonstrate, many non-duals experience similar circumstances and are not being addressed. What do you think about such a pilot that would be so focused?
Wasn't it part of the Healthcare Innovation Awards?
Not quite, to my knowledge.
Okay.
But you think it's a good idea?
I think it's a great idea.
Okay, that's terrific. That's good. So let's see what we can do about getting it done. Mr. Colman, very quickly on Minnesota, I am aware that based on work supported by the SCAN Foundation, that you are number one on their, Minnesota is number one, I'm sure you too, on their scorecard for long-term services and supports in the states. And it appears to me that you achieve that objective through a mix of providing targeted and a broad array of services, as well as, in terms of your quality assurance, a mix of regulatory as well as market-based or information approaches. Can you talk to us a little bit about the importance of regulation?
There should always be a regulatory framework, but again, we try to play the consumer choice element first and design the system around what people are choosing, how to receive their services, but regulations are still important and should be part of the discussion, but it shouldn't be the first thing we talk about.
Thank you.
Commissioner Pruitt.
Thank you. Thank you all for your testimony. It was very thought-provoking. I'm from the South, so I don't speak quite as fast as the two Judys. And that
I'm a Floridian.
that went before me, so please bear with me. Since you all are our second to last panel and we have the testimony of our next panel, I'd be remiss if I didn't comment on what this commission has not heard and provided comments to such of the lack of information. And I would say that one such is the common perception that there are a bunch of people in nursing homes that can automatically be moved out. And we produce a position paper on this at ahcancal.org that goes into this in much more detail. I am curious, though, if you accept the fact that we need to provide a more cohesive post-acute care system and long-term services and support system, how would one go about doing that? And Mr. Berger, in reading your longer testimony and working through the idea of a convener, I noticed that you said that a convener could be a post-acute care provider. Would you walk through that concept with us in just a little bit more, and how you would see the bundling work and how the provider would be possibly the convener?
Sure, happy to. Briefly, again, our focus is on ensuring that the model is the most implementable possible. There are lots of different approaches to this. Our view is what could actually be done in relatively short order for a number of different reasons. And our view is that a couple of key criteria must be met in addition to it being implementable. It needs to be sensitive to conditions within each community. And it also needs to be something that does not lump in things that should not be together, so that we don't end up overpaying or underpaying for any particular thing. And as a result, as you'll see from the model that we've envisioned, it really is a clinical condition-specific bundle. So in effect, there would be lots and lots of bundles. Now, as far as who's best to manage that, some thought is that the payment should go with the patient directly to the provider. But there are a lot of different stops along the way, as you know, of course, in the course of a patient's post-acute care experience. And so it didn't seem to be appropriate or logical, nor is there necessarily the capability there. So we thought there a higher level of capability would be required, a convener. Hospitals have certainly been talked about in that regard, but many hospital systems don't have the capability. Insurers, third-party benefits managers could be as well, but so too could certain post-acute care providers, each of which, though, in our view, would have to meet a set of criteria as related to their sophistication, their systems, their financial capabilities, and the like.
And further, and to my fellow commissioners here, point on the capital cost, and I know yours isn't a fully vetted proposal. Would you see room in your proposal of possibly distinguishing between those providers that do provide the housing and food and services versus those that do not? Is there room there to do further research and refine that?
Certainly, there's always room for further research and refinement, and in our view, there should be that type of an adjuster.
Okay. And my final question for you is, have you looked at potential cost savings from your proposal? Do you have any guesses into what it would score in terms of a saver?
Yeah, there's a 501c3 organization in the home health community, the Alliance for Home Health Quality and Innovation, and they undertook a 2-year analysis with Dobson DeVonzo Associates, Dr. Al Dobson's former chief of research at HCFA, looking at 3 years of Medicare claims data. And they modeled a number of different things, but including, it was part of their product, I'd be happy to provide to the Commission for consideration, is a savings model, which ranged everywhere from $39.7 billion over 10, if no particular goal were structured in there, all the way up to $100 billion. And the $100 billion in savings was if total spending under the bundle didn't exceed 92.5% of the baseline, which is an approach that's been used by Congress in the past, most recently with the dialysis bundle, wiring in a particular savings threshold. So we believe that it could generate, as I said in my testimony, potentially tens of billions of dollars that could help the program and potentially support long-term care.
And what would your recommendation be to this commission in terms of first steps? Have you put any thought into how this would be implemented over time?
It's a big undertaking. While we think that it's appropriate across the board, we do think that an incremental approach may be necessary for a whole host of reasons. In that regard, we would think to start with MSDRG 470 patients with major joint replacement without complication. It's the #1 most expensive code within Medicare inpatient, and we see a wide range of patients coming out, everywhere from that doubles player all the way to the 86-year-old gentleman with dementia who had his hip replaced. So a lot of different clinical conditions could be tested in that one DRG.
Great, thank you.
Again, my thanks to the panel for a terrific job. Actually looking at sort of the innovations is a wonderful place to be as we wrap up our public testimony. I want to ask 3 quick questions, but I want to sort of start out with the observation that I think fear retards our ability to make some of the changes we might want to do, sort of fear of the unknown. And I'd sort of put in front of you guys that one of the challenges we have is the fear of doing nothing, right? So that there is a substantial challenge that the commission understands that we face, but also a substantial responsibility to propose potential changes that make sense fiscally, clinically, organizationally, and that's just a really important challenge. So going down the line kind of quickly, Mr. Berger, I guess sort of my first question along that frame is, so I'm a doc, right, and worked in managed care at a different point in my life, and how do you know that when you start to develop these bundles that you're actually getting the right care for the right person at the right place, as opposed to just the cheapest care but might not actually be the best care? Because I think the fear of not being able to provide adequate consumer protection sometimes scares people about these sorts of proposals. How would you respond?
With two elements right off the bat. One is the convener, and therefore all the providers within that convener's network would be at risk for readmission. And so if the care was inexpensive but wasn't effective, and the patient within that bundle, which we think is about a 90-day, might be a stable model for that, they'd be then bearing the consequences of that short delivery of care. Number two, there's freedom of choice. That the beneficiary would be able to select the convener and therefore that network of providers that the convener is contracted with.
My next question is for Ms. Alecxih. So California doesn't have very many ADRCs. And I guess the question in my mind is, how do we get to, so talk to us a little bit more about the variation in performance you saw across ADRCs, and how do we get to a place where every, vulnerable older adult or every younger person with a disability has access to that kind of service? I mean, I worry that we're building something that could take a really long time, and there are needs now.
Resources always help. Like I said, over 10 years with very, very modest resources, it's managed to cover 70% of the population. California has been a particular challenge. It's a county-based system. There was honestly not a lot of leadership from the state. And where other states that took the lead and decided to adopt the model, Minnesota is one of them, their linkage lines are part of their Aging and Disability Resource Center infrastructure. So it was incumbent upon the states to decide that this is where it was going. And CMS has also endorsed the concepts through the Balancing Incentive Program and has been funding through CMMI grants and other sorts of things, those concepts, the SHIP grants. All of it is sort of dribs and drabs, and as the department is now coming together and looking at long-term services and support sort of across things, the hope is that a more, a common vision across all these different groups that need to be involved and is presented to the states and to the local communities in that manner would help, further that goal.
And just speak briefly to the sort of range of quality that you saw as you did your scoring work?
Sure. So our scoring work was a lot around the process and what they were pursuing and what they were able to do. So we weren't able to look too much at outcomes. Sort of the decline in Medicaid census was an attempt to look at some outcomes there. But it ranges. There's quite a few areas that they need to be focused on, and there's quite a few elements. Like I said, there's 30 different elements. And so the states that are, sort of behind and not doing so well are the states you might expect. And it has to do with things that Loren talked about in terms of vision and leadership and mission and going back to that and constantly improving.
So that takes me to Mr. Colman. So I think, you guys get tremendous credit for being willing to take risks in a practical and thoughtful way that have advanced the system. And I wonder about how we replicate that. And one of the things I think you guys have done successfully is get over the fear of the woodwork effect, because people will start to propose things and then people will say, well, we can't do that because it's just going to serve too many people. So in the few remaining seconds, talk about how you've been able to advance programs but take on that challenge.
Well, first of all, I think we start with the end in mind. What are we trying to achieve, and how would this play out over 5, 10, 20 years? We have in the hallway what we refer to as our Hall of Results. that is a poster board display of our initiatives, what we projected to achieve, and we monitor ourselves, and it's available to the public to see also. So, so that's one element. I think it's also kind of a moving target. What we're trying to do is not design the system for the current older person. We're trying to design the system for the future older person, which is many of us, many of the boomers. And what we are going to want to experience long-term supports with may be very different than today. Same thing with people with disabilities. What the next generation or the people with disabilities expectations for housing, employment, education, et cetera, is very different than what the experience has been.
My Vice Chair?
Thanks very much for everyone on the panel to provide a very interesting information. I had a question for Mr. Colman and a question for Ms. Taylor. If towards the end of your testimony, Mr. Colman, you say you have a report due to be completed in November 2013, too late for this commission, but perhaps you can give us a little bit of a preview. It indicates that there are 3 components to your initiative: public awareness, identifying products for the middle income market, and aligning Medicaid to provide incentives to individuals who use private financing. These are topics that the commission has great interest in. Perhaps you could just tell us a little bit about it.
Certainly. I don't want to take the responsibility away from the commission to find the answers to those questions. But we identified those as significant issues in Minnesota also, and that's what launched our initiative. We are currently working with an advisory group on product availability. What is out there in the marketplace today that particularly middle income, middle asset individuals have to choose from? And clearly the standard long-term care insurance policy, as most of us know it, isn't getting the job done in terms of people planning in that fashion. So we're looking at combination products. We're looking at other creative ways of using equity in one's home. We're looking at how we could design the next generation of partnership policies to consider. Again, partnership policies are available in Minnesota, and we think they're a good thing, but we don't think we need to stop there in terms of how it interacts with Medicaid. But no, we don't have the answers yet, and that's why we have an advisory group, which includes actuary people, insurance producers, consumers, providers. We're all wrestling with this together.
Okay, thank you very much. Ms. Taylor, at the beginning of your testimony, I believe, if I got this right, that you described a rather generous program, if I've got this right, to the veterans of post-9/11 conflicts for support for family caregivers. It's, if I saw the numbers right, it's a lot of money. It's $1.5 billion over 4 years. Did I get that right? So what's interesting, and as a researcher, and the other researchers on the panel might appreciate this, that's a very specific time differentiator. So in other words, somebody who was in a conflict just the day before doesn't get that benefit, or their family caregivers don't get that benefit. Somebody, the day after does get it. That would seem, that is what we call a natural experiment. It would seem like there'd be great information to find out what this very generous benefit does in terms of everything, in terms of the quality of care that's being provided overall, the cost, obviously, to the government, the disposition of the veteran, him or herself. Has anyone done this yet?
So our program of comprehensive assistance has been in effect, in place for approximately 2 years now. And we've looked at some very preliminary data on the outcomes of participants in that program. Small sample, very preliminary outcomes for both caregivers and veterans. And on the caregiver side, we've been, with that, again, preliminary data, small sample, been able to see that we have been effective in reducing caregiver burden. And then on the veteran side, we looked at the veteran care recipient participants in the program, and there was a significant reduction in the average inpatient utilization with those veterans. But again, further study is needed, and our population has increased pretty significantly in that program, and so we continue to study and monitor that.
That's great. And again, my emphasis is to, just to look at those in and those out, because that's really what the margin is what's important in terms of understanding the true effectiveness of this, very expensive intervention. Thank you.
Thank you.
I will add my encomiums to this panel. Thank you all very much. There has been a good deal of discussion among the panelists and among a number of witnesses about whether the seeming desire to move increasingly towards a home and community-based system for long-term supports and services is going to be a cost reducer or a cost enhancer, including woodwork effects or potential woodwork effects of the expansion of the population that will receive service. So in each of your contexts, I'm going to ask Mr. Berger, Mr. Colman, and Ms. Taylor to comment on whether or not you believe, and if you do believe, what is the evidence for the proposition that increasing home-based health care is going to reduce overall costs to the system for the population being served, similarly with Mr. Colman and similarly with Ms. Taylor.
Thank you. The data, of course, do demonstrate that the home-based setting is the most cost-effective of all settings, and it just tiers up. STIF is next, followed by IRF, followed by LTAC. But that said, this is not a case just of trusting that the outcome will match the data, but also, frankly, verifying it. In our vision for that evolutionary reform within Medicare, we have taken a look at that ESRD bundle that I mentioned before, which was enacted as part of MIPA, and did establish that total spending could not exceed a fixed percentage of the pre-existing baseline. In that case, it was 98%. So reform of this nature could include such a mechanism, if only to ensure that there would be savings to the program, the taxpayer savings made available for long-term care, and thereby increase, frankly, the incentives, if not the appropriate word being pressure, upon the conveners and all participants to ensure that they don't exceed that, because that would then be theirs to, as the term goes, eat.
There is also, excuse me, I'm going to ask one additional question on this. There is also comment that, in fact, there's an upfront investment for establishing the infrastructure needed to conduct this. So is that the 98% in this case? Does that include whatever upfront investments might have been needed in personnel and structures and in information technology or whatever in order to achieve that program improvement?
It does. We did not anticipate and aren't envisioning a specific fee for that for a convener or anyone in the system.
Mr. Colman, what has your experience been in Minnesota?
Sure. Well, first of all, these are tough decisions. We have not seen any evidence of a woodwork effect, and Minnesota has substantially moved to a home and community-based system. Just as I explained a little bit earlier, if our strategy has been around developing a comprehensive assessment tool so that we're really identifying what the individual's needs truly are, what their preferences are, what other informal supports they have that we want to continue to support and foster. And so the criteria by which you design what services individuals will be eligible for is really critical so that it's clear up front what they're able to receive. We have some very low-cost services that are appropriate for people at certain stages of their life. But then there are circumstances where 24/7 or institutional care may be the most effective way to deliver the service.
So you haven't seen woodwork effects. Have you seen an overall decline over your trend line in terms of costs, or absolute numbers, or per capita numbers? What have you seen in terms of costs?
Well, two things. We monitor the system both for institutional care as well as home and community-based care. So we look at the total system, and that's one thing. So as we have been able to achieve some closures of facilities voluntarily, we're able to take that high-cost model and are, in fact, able to serve more people in the community. We are bending the curve with these other initiatives. It's not simply sufficient to say everyone will live in the community and get the full package of services of whatever they want. So the housing access program that I referenced earlier, where those that wish to live in an apartment of their own with supports is much less costly than our typical corporate foster care. And so we're able to achieve savings and reinvest it into serving more people and provide more growth. We still have limits. We still have realities that we have to deal with, but we're trying to manage them concurrently as a total system.
Thank you. Ms. Taylor, you mentioned preliminary estimates of reduction in caregiver burden and some very preliminary numbers on reduction in inpatient utilization. Have you been able to ascertain even preliminary estimates of what the cost impact is? I mean, you have a very high investment in the program. Are you seeing, or is there even any preliminary estimate about what the cost savings might be as a result of reduction in inpatient utilization, whether acute or institutionalization?
So VA really takes a comprehensive approach to the long-term care and services and supports that we offer, and we have a wide variety of programming such as our home-based primary care program, our medical foster home program, the veteran-directed care program that we offer that certainly has more of that analysis and data has been done with those programs. But specific to the caregiver support program, it's still a bit early for us as far as coming up with the costing. It's premature.
Let me just ask about REACH. That's a 20-year program. States are implementing it. What has been the experience with respect to the REACH program in terms of its cost impact?
The REACH program, actually, Dr. Linda Nichols and Dr. Jennifer Martindale-Adams is who head up the Memphis VA Caregiver Center, and they have just applied for some funding to study better the cost benefits of REACH, and so that definitive answers around that intervention specifically aren't available at this time.
Thank you. Commissioner Anwar?
I thank you all for being here this afternoon and appreciate your sharing with us bullets of your experience and work, the important work that you all do. My question is just stepping back and looking at a bigger picture, something that we experience on a daily basis. I'm a physician and in practice as well as a consultant to healthcare industry. And what we find is that we know that the amount of money per person that we are spending in this country is a whole lot more than any other country on this globe. And we struggle with the fact that our outcomes are not necessarily as good as some of the other countries. And we find that we have systems that are not as efficient and as effective, and that when you change things, there are two big barriers the way I see them. One of them is a mental barrier, the fear of change, that it may be worse than what we have right now. And the other is the upfront financial investment that you need to make changes initially that may reap benefits in long term. You have to buy the seed before you can reap the benefits of that seed into a sibling. And so my question to you, Mr. Colman, would be that how did you start the ball rolling in the first place in Minnesota? How did you find the spark for this?
I would say that that a collection of people many years ago formed the conclusion that what we were doing was unsustainable. That there was a point in time when really poor choices were going to be the only options, and that if we didn't start doing something different along the way, we knew what our fate was. And so working collaboratively, governors, legislatures, because not only the current legislature or the current governor, it's been a tradition of saying, what is the vision for the future? And yes, there were some tense moments, but people came together, looked at a variety of options, long-term care commission that looked at what's life going to look like in 2030, and started making some decisions. Some of the funding that I identified were hard-fought battles to get some money, to test different programs, to provide some seed money, some venture capital, to existing providers to say, can you do things different? Or new providers who had never been in this field but came at it from a fresh perspective. But I think, the reality of what choices were going to be down the road that were going to be really poor, I think what drove people to say, let's try something.
Thank you. Ms. Taylor, a different question to you. And you mentioned briefly about some VA programs regarding spinal cord injuries and brain injuries. Could you speak a little bit more towards that as to what it is?
Sure. The REACH VA program was modified to specifically serve the spinal cord injury and dysfunction population. So that was late last year. Another thing that we've been able to do, based on some of the feedback from the core curriculum that we received from caregivers, they asked for additional training specific to post-traumatic stress disorder as well as traumatic brain injury. And we were actually able to use VA's employee broadcast system where we are connected to every VA medical center through our broadcasting system and have a speaker come in to our headquarters office here in Washington, D.C., and then have the local caregiver support coordinators invite in caregivers to be able to receive additional training specific to how to deal with someone with a traumatic brain injury or post-traumatic stress disorder. And the most recent one that we just completed was actually on pain management and caregiving issues.
Thank you very much.
Thank you again for all of your input and thought, and I especially want to thank Mr. Berger for his quoting Governor Kasich. Appreciate that, and his comments on passport. And I also want to ask Mr. Berger, you had talked about reducing regulations, and I assume you're meaning in a broad sense in terms of site-neutral bundling, but could you be a little bit more specific as to what kinds of regulations, and were you thinking about other areas as well?
Within the context of bundling, there certainly would be a fresh approach taken to the different sites of care. We, of course, have these siloed segments, and each of them have their own particular rules, restrictions, eligibility, or criteria, and the like. That would be replaced, obviously, with a new structure for a bundled payment system. If you're referring to some of the obstacles that I mentioned, too, that are kind of impeding access or delivery of efficient care today, then that goes to the response to Ms. Turner's question concerning face-to-face as a good example of something just within our space. The part that I left out is there's an existing form used in the hospital setting, Form 425, which could serve the purpose of a face-to-face. We have a duplication of requirements, which is actually creating a documentation problem.
Thank you.
You bet.
A question for Mr. Colman. First of all, you mentioned that you have put together a statewide phone number for your APS system, Adult Protective Services, and I gather some additional funding for APS. Is that correct?
That is correct. It's in development. It's not live and operational yet.
Oh, okay, because I was curious as to how much additional funding you were putting into the program, and also how you see APS working into the general populations we've been talking about, and whether you see that as a force in helping to reduce the need for care or to deal with costs of care.
Well, the way our process works is we were able to put together a package of reforms, and what we labeled Reform 2020. And so there were a variety of initiatives within that that saved money, and then there were some initiatives that created a need for investment. Overall, it was budget neutral, and that's how we were able to successfully get some additional funding for reforming our adult protection system. Again, the reality is, as we're moving to a dispersed system where people are living in their own homes, perhaps alone, perhaps with another family member, we're going to have more circumstances where people's vulnerability may be enhanced, and we need new tools with which to try to identify those as early as possible. Interesting conversation that I recently had, which, you know, again, we don't know everything, but a U.S. Postmaster identified for us that she and her colleagues are basically going past every home 6 days a week and know who's living there and where they may be vulnerable. And so we're going to have some conversations about how we can leverage that resource more effectively. So again, it's creating the dynamics and then the solutions.
And another question for you, you were, mentioned the housing issues as well, and the potential, or perhaps you are funding some housing and food assistance for folks. Could you talk a little bit about how you're combining, what your process is in terms of who you're finding is needing that? Are you also finding a scarcity of housing? And are you combining housing and services in, say, 202 projects or something of that nature?
Okay. Again, we try to be very focused on the individual. And if an individual wishes to move from an institution to an apartment or a home of their own, then the process will be to identify the service package and then the appropriate housing funding. And again, we're fortunate the state of Minnesota has provided some limited resources for housing that we're able to use for those individuals who wish to move. It's always a challenge. The stock of affordable housing is always a challenge for us. And there's always competition for those units.
Thank you.
Thank you, ladies and gentlemen, as well. Mr. Colman, I have a couple quick questions because I found your comments and some of the points that you made very intriguing. Following up on one of George's questions, you had a chart, this chart, in your presentation. And I took a quick look at that, and this is the forecast of what you anticipate expenditures to be from 2013 to 2017 in the DHS budget for Minnesota. In looking at that, I just did some quick calculations, and the home and community-based services is projected to grow at an average annual rate of 10%. And the institutional line is relatively flat, almost low. Alternative care is relatively flat, and the total budget goes up about 6% on an average annual basis. So going back to the woodworking effect, that seems to me to be a high rate of growth, projected growth. And if there's not woodworking, what's causing that?
The way we do our forecast or construct our forecast is according to current law. So what you see in front of you is the current law as it plays out. what you don't see in there yet are some limits in enrollment, particularly on the disability waivers. We manage the growth in the disability waivers with enrollment caps, so to speak. But those are decided biennial budget by biennial budget, so they're not permanent caps. They're flexed along the way. On the elderly side, if you look behind the detail, which you don't have, it's a much smaller growth rate. But that's more a function of the demographic hasn't hit yet, where we're going to have many more people who will be of that age whereby which they will need supports. And if we don't successfully deploy some of the strategies that I talked about earlier, they will become dependent upon Medicaid for their support. So we still are experiencing growth, there's no question, but it's moderated from what it was 5 and 10 years ago.
So if that's not the real growth, I mean, do you know approximately what it would be, or?
I don't understand your question, sir.
I think
this is the growth according to current state law.
Okay.
But typically, each biennial budget has seen the application of enrollment restrictions on the disability waivers, which then would moderate that growth curve.
Okay, so you would, in a practical world, expect the growth rate to be lower?
Correct.
Okay. Okay. A couple of very quick questions then. You talked about a web-based uniform patient assessment methodology, which I compliment you on. Can you answer very quickly, who did it, how long did it take, and what did it cost?
Well, the state of Minnesota has constructed the tool with input from hundreds of people who all have their idea of what the questions ought to look like, what the modules ought to be. There's probably 5,000 questions in the tool, but no single individual will be asked 5,000 questions. The tool will lead the interviewer through the various modules that are appropriate for that individual. It has been in development we received funding from the state of Minnesota in 2009. It's been a concept for probably 5 years prior to that, but have never been able to receive the funding. And I'm hesitant to attach a specific dollar figure, but it was several $1 million.
One last question. The reduction in nursing homes, you cited closures. Was there a buyback program, or was there some other methodology that was involved there?
We have had incentives for providers to plan closures, either totally or partially. There's been incentives to create single rooms where we will pay providers to take doubles and triples and create singles, so they're able to receive some additional fundings to recognize some of the fixed costs. There have been some total closures where we can calculate the savings attributed to a closure of an institution, and part of that savings can be attributed to the rate of another facility, either owned by the same organization or others in the same community. So we've had some tools to recognize that businesses need some support, either to downsize or to exit the business.
Great. Thank you very much.
I'll be the last and final to say thank you. Thanks, no, seriously, for all of your time and preparation to come before the commission today. Mr. Colman, since you were just speaking, why don't we keep it going?
Sure.
And talking about nursing homes, you had a chart that talked about your intentionality and success, as you described, of keeping and moving individuals to the community. You talked just briefly about some of the initiatives that the state had taken with the nursing home providers. Are there other things that are happening that is making this such a successful program? Because as you heard from, I think, Mr. Pruitt, there's been some debate about whether or not there is money to be saved or people who are available to be moved into the community out of facility settings.
Well, I think what we've seen in Minnesota is substantially nursing home providers becoming quite diversified, looking at their business model, whether they're for-profit, not-for-profit, government-owned, that they are the aging experts of delivering service. At least that's the way they portray themselves. And so they've diversified into assisted living, housing with services, home care models, et cetera. So the shock to their organization of closing a nursing facility or downsizing a facility to provide a different product mix has not been as severe. In fact, many organizations have had revenue growth as they have become more diversified and more consumer-oriented as to where do people prefer to receive their services. And again, those other models of service that are not providing 24/7 care are typically less expensive.
Sure. And then just, have you been able to calculate the savings the state has been able to experience specifically around the work that you're doing, keeping folks moving or keeping consumers in the community?
We are always calculating the next initiative, and what we're also doing is putting an evaluation component into each of our initiatives to look backwards to see what we have saved. Again, because of the public nature, I'm hesitant to give a number, but we did produce some documents for the legislature recently, and over the previous 5-year term, like 2007 through 12, I believe we documented about $700 million of savings.
Thank you. Mr. Berger, thank you for raising the issue of the workforce. It's been it's a direct charge of this commission, as folks may have seen in the statute itself, as to our work. And so I really appreciate you reminding us of the significance of the economic engine that the home health and home care services industry is going to be for our country. One question that I have is, along with the information that you have provided us, are there specific workforce development initiatives that your group is thinking about or proposing or would find helpful as the industry is growing and businesses, I'm sure, are planning?
Thanks very much for the question. There are, and I'd be happy to follow up with further detail. One of the ones that we are focusing on as a community is the ability of nurses to engage in the recertification of patients under the physician's orders, just because the physician resources stretch so thin, the nurses have direct contact with the patients. It's actually pending legislation here in Congress, which would stretch the capabilities of the workforce.
Great. And then, well, I know maybe some of your member organizations, but to go may not necessarily provide the non-medical services, but maybe some of them do. And could you go a bit beyond the medical? Is there any thought about beyond the medical services workforce?
Education and training are obviously critical criteria. There are partnerships with colleges, community colleges, other programs, high school outreach as well. It's a tremendous opportunity for a lot of folks to get engaged into a level of care and a professional track that naturally appeals to them. As a community, we have a wide variety of different initiatives. I can't speak with authority what states are doing, what the federal government has available, but I know that the members do, so I'll follow up on that.
Thank you.
You bet.
So I want to take this opportunity to be the very last person, to thank you guys for a really wonderful set of presentations. Thank you for bringing so much creativity to this discussion, and I hope all of us on the commission can capitalize on the good ideas you've shared with us. So thank you again. If we could have the next panel come on up, that'd be great. Okay. I'm going to wait just one more moment to regain a couple of commissioners before we start. Okay. I'd like to welcome all of you to our second panel for the day for the Long-Term Care Commission. In this panel, we're going to focus on workforce innovations and related issues. We have four wonderful presenters. We're going to begin with Tracy Lustig from the Institute of Medicine.
Thank you. Good afternoon, Chairman Chernoff, Vice Chairman Warshawski, and distinguished members of the Commission. Thank you for the opportunity to testify before you on the critical challenges facing the overall workforce for long-term services and supports. I come before the Commission in my capacity as the staff lead for the Institute of Medicine's Committee on the Future Healthcare Workforce for Older Americans. In 2008, the committee released the report Retooling for an Aging America, Building the Healthcare Workforce. This report defined the workforce broadly, that is, to include professionals such as physicians, nurses, and social workers, direct care workers, your nurse aides, home health aides, personal and home care aides, family caregivers, the friends, family, and others who provide supports and services, and even consumers themselves. As you know, long-term care includes an array of health care, personal care, and social services for both younger and older individuals. The 2008 report I am representing primarily focused on the healthcare aspects of long-term services and supports for older adults. However, as the report itself states, healthcare services are often intertwined with personal care services and are often provided by the same workers. Therefore, many of our conclusions and recommendations are applicable to the long-term services and supports workforce more broadly. To begin, we're all well aware of the dramatic aging trends and needs for long-term services and supports predicted in the near future, and so the question arises, how adequate is our workforce supply to meet these impending needs? And the answer is quite simple: we're woefully unprepared. There is a considerable shortfall in both the quality and organization of the workforce. I would like to take a step back and review some of our findings about the different segments of the workforce and then summarize our key recommendations. So the need for healthcare professionals trained in geriatrics is escalating, but few providers choose this career path. Geriatrics education and training is hampered by a scarcity of faculty, inadequate and variable academic curricula and clinical experiences, and a lack of opportunities for advanced training. Furthermore, recruitment is hampered by persistent stereotypes of older populations and significant financial disincentives. And while the professional healthcare workforce is important, for long-term services and supports, we need to pay particular attention to the direct care workers and the family caregivers. Direct care workers are the primary providers of paid hands-on care for older adults. They work primarily in community-based settings and often provide clinical services, plus assistance with other services and supports such as bathing, dressing, housekeeping, and food preparation. Direct care workers have rewarding but difficult jobs. They have high physical and emotional demands placed on them and significant potential for on-the-job injury. Additionally, direct care workers are typically very poorly paid. They are more likely to live in poverty, to lack health insurance, and to rely on food stamps than other workers. Direct care workers often receive inadequate training for their duties. Federal minimum training requirements exist for some types of direct care workers, but these have not changed in over 25 years. Some states require more hours than the federal minimum, but both the quality and quantity of this training has been questioned, and no federal minimum training standards exist for personal care aides. Other factors that contribute to job dissatisfaction include poor relationships with their supervisors, a lack of respect from other healthcare providers, lack of involvement in the care planning process, and few opportunities for advancement. As a result of all these factors, turnover rates are high among direct care workers in all settings of care, which may in turn lead to poor clinical outcomes. And overall, the number of direct care workers is insufficient to meet demand, which will be exacerbated as care continues to shift from institutional settings to the home and community. In 2001, the Institute of Medicine stated that one of the most important barriers to the expansion of personal care services and home and community-based service waivers was the shortage of direct care workers, particularly those working in the home. And consumers play a sizable role in their own care, not just as recipients of the services and supports, but as prominent actors in the delivery process, such as through disease self-management and care coordination. In spite of this, little is done to recognize their role on their own care team. Moreover, public policy has traditionally viewed family caregiver service as a personal moral obligation and not as an extension of the workforce. However, family caregivers are the predominant providers of long-term services and supports, and in general are thought to provide task assistance that is low cost, high quality, and consistent with individual preferences. And while family caregivers take on increasingly complex responsibilities such as wound care, medication administration, and care coordination, little is done to prepare them for their role on the care team. So the Institute of Medicine Committee recommended steps to be taken along a three-pronged approach. First, we need to increase the competence of virtually all members of the healthcare workforce in the basic care of older adults. Second, we need to increase the number of providers with expertise in caring for older adults. And finally, we need to change the way that care is organized and delivered, including the way we use the workforce. So in terms of enhancing geriatric competence, the committee recommended demonstration of basic geriatrics competence as a part of licensure and certifications. They specifically recommended the expansion of professional training in non-hospital settings. As we know, most residency training occurs in the hospital and not the places where older people receive most of their care. They also recommended increases in the existing minimum training standards for direct care workers and the establishment of minimum training standards for personal care aides. Additionally, individuals and the family and friends who help care for them need to be better integrated into the healthcare team. For example, as I said, family caregivers are playing a larger role in delivery of increasingly complex healthcare services at home, so we really need to be making training opportunities available to them. Recruitment and retention of all types of workers is challenging, most often due to serious financial disincentives. The committee recommended policies and programs that provide loan forgiveness, scholarships, and direct financial incentives for professionals who become geriatric specialists. And the need for direct care workers is particularly dire. To improve the quality of these jobs, more needs to be done to improve job desirability, including greater opportunities for career growth, increased pay, and access to fringe benefits. But simply expanding the capacity of the current system will not be sufficient. New models of care show great promise to improve the quality of care and reduce costs. However, the diffusion of these models has been minimal, often due to the fact that current financing systems do not provide payment for features such as patient education, care coordination, and interdisciplinary team care. An interdisciplinary team implies an interaction and interdependence among providers with different areas of expertise working together to care for an individual. Still, professionals are typically trained separately by discipline, and as a result, they may gain little understanding of or appreciation for the skills needed to effectively participate in a team, or for the expertise and contributions of other providers, including direct care workers and family caregivers. For example, in 2001, the Institute of Medicine report Crossing the Quality Chasm noted that providers should involve family and friends as appropriate in decision-making and recognize their needs and contributions. It is further noted that a major challenge in transitioning to a 21st century health system is preparing the workforce to acquire new skills and adopt new ways of relating to patients and to each other. Finally, more research is needed on how we can best maximize the use of all the members of the healthcare workforce. Many new models of care require workers to assume new roles and responsibilities. Shifting these various care responsibilities will improve efficiency, but will also require training to impart the skills needed both to deliver more technical services, as well as the skills needed to be effective delegators. Additionally, the committee supported the development of various technologies that would enhance the capacity to provide care. As a footnote, I'd like to add that in the 2012, the Institute of Medicine released a complementary study to the one I've been talking about, which focused on mental health and substance use workforce for older adults. And this report reemphasized the main findings and conclusions I've discussed today, again, including the roles of direct care workers, consumers, and their families. So in conclusion, I'd like to acknowledge the immense task this commission has, and while there are many important issues, I'd urge you to remember the workforce that delivers the services and supports you are considering, because the bottom line is, even if all the other challenges are met, it won't matter if there isn't anybody there to provide the care. Again, I want to thank the Commission for allowing me to testify, and I look forward to questions or comments you may have.
Thank you very much. Now we will hear from Suzanne Mintz from the Family Caregiver Advocacy.
Of the commission, especially because you've given me a second chance. I was invited to speak last month and was unable to, and so I appreciate that you've called me back. I'm Suzanne Mentz, and I've been a family caregiver for 39 years and a family caregiver advocate for 21. Currently as the founder of Family Caregiver Advocacy, but for the majority of my career as the co-founder, president, and CEO of the National Family Caregivers Association. My husband was diagnosed with multiple sclerosis, an incurable degenerative neurological disease, when he was 31. Not an unusual time because MS is a disease of young adults. But that was a long time ago. Last month he turned 70 and now needs help with all of the IADLs and ADLs, as well as some medical interventions on a daily basis. And I am not alone in this. 46% of family caregivers are now providing medical care. So I am actually breaking nurse practice rules on a regular basis. And I hope you won't report me. We do have help 2 evenings and mornings a week, but I am Stephen's primary caregiver and also his unlicensed nurse. Because I came to caregiving as a young adult, and because my husband has a chronic disease that over time has severely disabled him, I've never believed that long-term care is solely an issue for a senior population, nor have I believed that it's primarily about getting goods and services to those who need it in the community or ensuring that nursing home care meets high standards. I believe that care over a long period of time for anyone who cannot care for themselves in an age-appropriate manner requires an integrated approach to that person's health, their goals, and their overall well-being, and that of their primary caregiver as well, who most likely is a family member or close friend. This belief has led me to a number of ideas on how to approach the provision of long-term care. Not all of these are my own ideas. Some have been tested, others not. But together, they begin to create a picture of how life could be healthier, safer, and less stressful for those with long-term care needs and their families. My first idea is that a person with chronic care needs, regardless of whether it came from a disability or an illness or the frailties of old age, and his or her family caregiver should be viewed as a dyad and treated as such in terms of medical care and needed services. What affects the caregiver affects the patient and vice versa. My health has a direct impact on Stephen's care. An actual example of this is several months ago, I fell down the stairs in the middle of the night. Don't ask why I was going downstairs in the middle of the night, but I broke a toe and I wrenched my shoulder at the sternum clavicular joint, which you really need if you're doing a lot of lifting, which I do. Now, because of that, I wasn't able to do what I normally would do. And so, in theory, Stephen needed some home care. But nothing had happened to him, so insurance would not cover home care services for him. And having a broken toe and a wrenched shoulder is hardly reason for home care. But if we were thought of as a dyad, if we, the family mints, were viewed, then perhaps that kind of situation would not arise. The dyad concept is certainly antithetical to how we provide and pay for long-term care today. And it raises complex issues of how you might do this, especially because patient and caregiver may not even be on the same healthcare plan or have it paid for by the same entities. I do not know the answers to any of this. I just pose it as something that I think is really important that we need to try and put in place. My second premise is that family caregivers need to be documented on their loved ones' medical records and on their own in order to assess, train, support, and enhance their ability to function as successful members of the care team and to have their own health care monitored. We don't exist anywhere. There is no record of us. When a baby is born, they get a birth certificate, but nobody knows who the family caregivers are. I actually wear a bracelet or a dog tag, a medical tag. it says my name and that I'm a family caregiver and that my husband has MS and would need help. And there are 2 phone numbers. So if I got hit by a bus, somebody would know. But in terms of medicine, family caregivers are not documented. And I am working currently with Kaiser Permanente, Booz Allen Hamilton, and the Coalition for Transform Advanced Care. And we are planning a summit for October to discuss these issues and figure out what a model might be for implementing some pilot studies. A third point, it is essential to assign care managers to designated caregiving dyads. An active and multidisciplinary care management team can provide support, education, and training, and alert the healthcare team to changes in symptoms before they become, really problematic. And they can do the coordination between healthcare providers and the social service system. The ADRCs are great, but it should not be the job of the patient or family caregiver to be making those phone calls to find out what resources are available. It is much more appropriate for a care manager, a navigator, whatever terminology you want to learn, to help put the options in front of that family so that they can then make decisions. They've got plenty of other things they need to deal with. And community health teams are a proven way to support patients with complex needs and their family caregivers. Several states have tested the concept via Medicaid waivers. I believe there's a link in my testimony. North Carolina, Vermont, Rhode Island are among the states that have done this. And there is actually a little-known provision within the Affordable Care Act that calls for the creation of community health teams to support patient-centered medical homes as part of CMMI. It's section number 3502. It's not been funded, so we haven't been able to see more of this concept. But the idea of community health teams, to me, integrates health and supportive services. I think we need a chronic care benefit in Medicare. Maybe you call it chronic care / disability. But the idea is that long-term care is an expensive proposition, as we all know, whether it's provided in a facility or at home. Private long-term care insurance has not proved to be a highly successful means of covering the costs. Class Act provision has been taken out of the ACA. There have been other solutions proposed for helping family caregivers, with financial issues. But if we had a benefit that included X number of hours of non-medical home care service, that would help families not have to pay for all of it out of pocket as they do now. And there are other products and services that are used by many families that, again, are not covered by anything, and it comes out of their pockets. And it's interesting that Medicare will pay to fix somebody's broken hip, but they will not pay to do what's necessary to prevent the person from falling and breaking their hip in the first place. I hardly have any time left, and my next 2 points are really about supporting the growth of volunteer communities. There's never going to be enough money or enough paid people, and I believe we need to go back to that old concept of barn building, where neighbors helped neighbors. And there are initiatives out there currently that are working. One is called Lots of Helping Hands, and it's a website that allows family and friends to come together and form a team. On a broader system, there is the Village Network that goes beyond family and friends and allows communities to come together to set up both volunteer and paid service organizations. And I think those are all at the tip of the iceberg, that we need to encourage those, and that will help us with this ongoing problem of long-term care that is not going away. Thank you.
Thank you very much. And now we'd like to hear from Carissa Rayner from the SEIU Healthcare Northwest Training Partnership and Health Benefits Trust, please.
Chair Chernoff and Vice Chair Warshawski and members of the Commission, thank you. My name is Carissa Rayner. I'm the Executive Director of the SEIU Healthcare Northwest Training Partnership. And the Training Partnership is a nonprofit school training more than 40,000 home care workers annually. We are the largest educational institution in the nation dedicated to home care worker training. I've been asked to share with you insights from on-the-ground implementation of what I believe is the nation's most ambitious training and workforce development initiative for home care workers. And thank you for having me again. Washington State has led the nation in providing home and community-based service options. We're in front of a nationwide trend to rebalance. In Washington State, people receiving home care services would in other states be receiving those services or may be receiving those services in nursing homes. Others have testified before the Commission and in other venues on the need for more home and community-based service options to meet the impending and unprecedented demand for services and the overwhelming preference of those individuals to receive those services in their own home. And much has been said about policy measures to finance and organize home and community-based service options to meet this need. These are truly exciting times. And as we move forward towards more and more home and community-based service options and away from institutional care nationally, I suspect we will find what we've found in Washington State. And that is, as Tracy also has pointed out, that home and community-based service options are only as good as the workforce we have to operationalize them. And right now, across the nation, we are dangerously short, both in terms of number of workers and the skills needed to meet that need. Home care workers are the fastest growing occupation in the nation, not in healthcare, but across all occupations. It's been said before, but I think it bears repeating. And by 2018, demand for home care workers will increase by 90%. So what does that mean in terms of numbers? Let's take Washington State, for example. In Washington State, assuming just a 35% turnover rate, which is liberal, because turnover rates exceed that across much of the country, nearly 440,000 home care workers would need to be trained between 2010 and 2030 to meet the estimated demand. How do we train so many workers with such limited infrastructure across the states today? What should the training look like? And will training not only support goals of quality of care and quality of life, but also improve turnover and vacancy rates, thereby improving access as well? To answer these questions, we need to have at the forefront that our goal cannot be limited to keeping people outside of institutions. In Washington State, our goal is making sure that people who want to stay in their own home and receive services can, and very importantly, that those services are high quality. That goal is 100% reliant on having a qualified, committed home care workforce on the other side of that front door. So having home and community-based service options is the start of the conversation. It's not the end of the conversation in terms of how we ensure that older adults and people with disabilities have a qualified, committed home care worker when they need one. Any examination, again, of home and community-based service options on the national front can benefit from lessons learned in Washington State. As Washington rebalanced, the care needs of home care consumers shifted from chore and companion care to much more complex care needs. So today in Washington, we have home care workers supporting individuals with serious mental illness, end-stage dementia, developmental and intellectual disabilities, spinal cord injuries, traumatic brain injury, and complex chronic disease. And they do it without a nurse, supervisor, or a peer down the hall by design. And they do it not in an institution, importantly, but in someone's home. So with the expansion of home and community-based services in Washington came a growing recognition that home care workers were being asked to provide nursing home level care with really a fraction of the training that their peers in nursing homes had. And recognition that this skills gap was leading to a serious and expensive problem. High vacancy high vacancy rates and high turnover rates, as well as quality of care and consumer satisfaction concerns were emerging. So in response, Washington State, and Chair Chernoff, I want to use your word risk, Washington State took a risk. They said, we are going to create the nation's highest training and credentialing requirement for home care workers. 75 hours of entry-level training, a Washington State Department of Health credential, and 12 hours of annual continuing education, approximating the certified nursing assistant federal requirement for training and credentialing. So since there is no federal training requirement for home care workers, as there exists for nursing home workers, most home care workers across the country have little or no training. And as Tracy points out, the IOM report, Caring for an Aging America, does note that training requirements for home care workers are insufficient, and we should establish a federal standard. Without a minimum federal standard, one can imagine that as home and community-based service options expand across the country, more and more states are going to face this skills gap that we experienced in Washington State, and we can head that off now, and I think we should. So I want to fast forward you now into that home and community-based services future that so many have talked about, and want to share with you the implementation of the nation's highest training and credentialing standard for home care workers. Again, the Training Partnership is a nonprofit school. We were created and are sponsored by a labor management partnership, including the state of Washington, SEIU, and about 20 home care agencies. We deliver training to more than 40,000 home care workers in Washington State annually. To succeed in training this many workers, we've had to overcome challenges of a disaggregated workforce over rural-urban divide, linguistic diversity, and also varying degrees of tech literacy and just literacy. We've learned to overcome these challenges, and other states can too. We know that quality in long-term care, like health care, is not enough, that we have to be mindful of cost. And healthcare worker training is part of the triple aim of better health, better care, better cost. That's why our training model was developed to prioritize affordability by emphasizing economies of scale, self-serve solutions, and rigorous utilization management. In terms of training content itself, we take our cue from consumers, workers, and industry. We emphasize 5 key areas. First is mastering the core skills to support ADLs and IADLs safely. Second is how do you individualize those core skills to meet the unique needs of a consumer. Third is care context, including applied understanding of mental illness, dementia, chronic disease, intellectual and developmental disabilities, spinal cord injuries, traumatic brain injury. Fourth is professionalism, which includes communication, problem solving, maintaining professional boundaries, self-care. And lastly, fifth is connecting to the care team, where appropriate, which includes observing and reporting to the care team any significant change from that consumer's unique baseline. So I want to say one more thing before I move to my close, and that's about the infrastructure itself. So we are delivering training in classroom and online environments. We train in over 100 sites across Washington State. We deliver in 13 languages, which really makes us unique: Arabic, Cambodian, Cantonese, Korean, Laotian, Samoan, Somali, Spanish, Tagalog, Ukrainian, Vietnamese, and English. We use adult learner-centered pedagogy, which means all training engages the experiences that the learner brings to the table. We curb the traditional theory and make it 100% applied. We develop training from the position that consumers, workers, and industry know what they need, and we have a rigorous process to understand their needs and then crosswalk that with subject matter experts and the published evidence base to publish relevant, engaging, evidence-based adult learning. We have a rigorous quality assurance program to maintain consistent quality across the state, and we're very proud of a 93% satisfaction rating from our students. So I've described to you the basic model of training in Washington State. I have little time left. If I had more time, I would go into career pathways, and will just tell you that this foundation has created an opportunity for us to build the first scaled career pathway for home care aides or home care workers in the nation. It is a U.S. Department of Labor registered apprenticeship for advanced home care aides. So in conclusion, I want to urge the Commission to consider embedding the following recommendations in your report to Congress. First, we need a federal minimum training standard for home care workers, just as we have for certified nursing assistants in nursing homes. It's not enough to create policy change that strengthens home and community-based service options. We need to concurrently create policy change that strengthens the home care workforce so that they're positioned to deliver on our hope for home and community-based options. It will not work, as Tracy and others have said, it will not work without them. Observers may ask whether we can afford a training standard for home care workers. My view is that the cost of higher training standards for home care workers will be more than offset by decreasing turnover and vacancy rates, and the value will grow as quality and satisfaction grows in the market, which is, as everyone knows, is about to be flooded by baby boomer demand. Training is not the only answer. I want to emphasize that to the structural challenges facing home care, but it's essential to meeting people's long-term care needs and offering a real alternative to expensive institutional care. Second, and lastly, we need better data. We need HHS and DOL to come together collaboratively to build out data systems so we can better monitor this workforce and how these different initiatives are impacting quality of care and return on investment. Thank you.
Thank you very much. And finally, we'd like to hear from Charlene Harrington from the University of California at San Francisco.
Thank you very much for the invitation to speak to you today about the importance of regulation and quality and the workforce. We cannot ignore the fact that many long-term care services have serious quality problems. And I want to talk about three things that I think are related to these quality problems: the lack of funding and support for regulatory oversight, inadequate staffing requirements and training requirements, and the lack of financial accountability. The nursing home industry, I'll start with it, uses the most resources in LTSS, and 63% of the funds are paid for by government. Following a report by the Institute of Medicine Committee that I served on in 1986, Congress passed landmark legislation to improve the quality and regulation of nursing homes in 1987. A comprehensive regulatory system was set up for nursing homes, which includes annual on-site unannounced visits, complaint investigations, and issuing deficiencies for violations. But the main problem with the oversight system is that there is an inadequate amount of resources to support the system. On slide 6, we can see that nursing homes report many serious quality problems, and much of this can be improved by good nursing care. In 2012, nursing homes reported that 21% of residents had antipsychotic drugs. Many had lost weight. Physical restraints are used. Many have pressure sores, untreated pain, urinary tract infections, and physical declines. Slide 7, almost all nursing homes have some violations of the regulations, and 1/4 of nursing homes have practices that have caused harm or jeopardy to residents based on our government surveys. Research shows that regulatory oversight is essential to ensure a minimum level of quality, and if you have increased regulatory funding, it results in stronger enforcement. Recently, our research has shown that higher state regulatory requirements results in higher staffing and improved outcomes in nursing homes. But basically, the funding has not kept pace with inflation, and we'd like to see the funding tied to a % of the government expenditures for each of the provider types in LTSS. Now, one of the critical components to ensure quality is to have adequate nurse staffing levels. There have been over 100 research studies showing that higher staffing, especially RN staffing, is related to higher quality of care. And this, we don't need any more studies on this, but yet the staffing varies, and slide 10 shows it varies widely across the different types of ownership groups. The 10 largest for-profit chains in the U.S. have the lowest RN and the lowest nurse staffing levels. And 70% of the nursing homes have nurse staffing levels below what is recommended by a CMS study. Looking at slide 11, we can see that RN and total staffing is directly related to quality. The deficiencies are highest in the top 10 or the 10 largest nursing home for-profit chains in the U.S. Only the nonprofit nursing homes and the government nursing homes have adequate staffing, and they have the lowest level of quality problems. Now, there are many problems with the inadequate numbers of direct care workers in nursing homes. And this is related to the low wages and the high turnover. And then this is also related to these individuals have a lack of health insurance, high injury rates, and the training standards of the 75 hours are just completely inadequate. We require training of 1,500 hours for a hairstylist, and yet we think we can trust only 75 hours for nursing assistants in nursing homes. We know what the nursing home staffing should be based on the research report done by APP for CMS, and it documented that we need at least 4.1 total nursing hours per resident day. So we think that government should set up a minimum staffing standard, and if it did, this would improve the quality. In 1997, Medicare established the prospective payment system, and it did result in cutting costs, but it made the quality worse. It encourages nursing homes to overinflate the acuity of the residents, and there are no audits done of the nursing acuity, so they get higher payments. But the worst part of it is that nursing homes are not required to actually deliver the nursing staff and the therapy staff that they are paid for. They're allowed to shift as much money as they want into profits and administrative costs. Slide 15 shows that since profits have more than doubled for Medicare just since 2003, in for-profit facilities, which have more than double the profit rates of the nonprofit facilities. We studied the revenues for Medicare and Medicaid and all payers in California, and we found that the nursing home profit rates have increased by 90% just between 2007 and 2010. And the amount of revenue spent on direct care for nursing staff went down. As profits go up, the nursing went down. So the research shows that the problems are directly associated with excess profit taking and the fact that we have no accountability for the money that we are spending on nursing homes. So we're recommending that we place ceilings on the profits and the administrative cost of no more than 20%. And that would result in a fairly sizable savings, and it would redirect money into the actual care of residents. Now, assisted living facilities or residential care have many of the same problems that nursing homes have, including quality problems and deaths. And many of you probably saw the recent expose on Frontline about some of the better nursing home, assisted living facilities and their quality problems. The problem is that there's no Medicare funding for assisted living and very little Medicaid funding, so there's no government funding for regulatory oversight at the federal level. So states have very minimal regulatory requirements for assisted living. There's almost no nursing staff required, no training requirements, no data reporting on quality, and no financial accountability, because they can also take as much as they want off in profits and administrative costs. Now, home care also has quality problems. There are very infrequent surveys of home health care agencies, and Medicare does not post information on deficiencies and complaints for home health care agencies. There are no standards at all for the number and type of staff and the number of visits. There are no limits on profits and administrative costs, and there's inadequate funding for the oversight of home health care agencies. Home care and personal care also have problems in terms of quality, as was mentioned here, because of the unstable workforce, the low wages they receive. So there are problems, and there's very little funding for oversight of the personal care programs. I want to point out that market-based approaches do not really work to ensure quality in LTSS. First of all, quality measures are self-reported and they're not audited. And there's an incentive for providers to report, to not report all the problems they have. Also, the highest quality providers usually are the most expensive. And so individuals on Medicaid or low incomes do not have access to the high quality providers and the best providers. Also, many of the managed care companies and the private insurance companies are contracting solely based on cost. They're not looking at the quality, even though the Medicare reports many quality measures on its website. So this, a market-based approach puts a tremendous burden on individuals to try to find out what places have the most quality or what services are high quality, and then to try to obtain those providers that have the best programs. So in summary, I would hope that the Commission will recommend to Congress that we shift away from focusing on controlling cost and that we focus on improving quality and accountability. We need to increase the funding to improve the regulatory oversight for all LTSS programs. We need higher and more explicit staffing standards for nursing homes, assisted living, and home health care agencies. And finally, we need to increase the financial accountability for the funds that we are spending on long-term care, with putting limits on administrative costs and profits and having an audit system. Thank you very much.
Thank you very much. We'll begin with Commissioner Butler, please. 5 minutes of questions.
Thank you. And thank you, ladies. I think a long overdue set of information for the Commission to hear, but glad that we got it from such advocates today. I wanted to start, Ms. Lustig, with a comment that was in your information about including the family caregiver as a part of the care team. Ms. Mintz, I believe you mentioned reference to the dyad. I wanted to get a sense from both of you, actually, your thoughts about an evolving model of care where not only the family caregiver is included in that care team, but Ms. Mintz sort of creating a triad where some instances is a family caregiver as well as a paid caregiver that's in the medical team, the treatment team, and a part of the care plan, and there's again, a sort of, especially in California where I am, an evolution of how personal care attendants, home care aides are being thought of as a part of that care team and a vital resource for observation, monitoring, early prevention. But there was a specific point made in the Institute of Medicine report. Ms. Mintz, you're living this experience with your husband. I just wanted to get you guys' response to that idea and the evolving nature of how care is being delivered.
Thank you, and I would agree a lot. It's interesting, the Institute of Medicine actually put a report out in 1978 that talked about the need for healthcare professionals to be trained in geriatrics. So, nothing we're discussing, as everyone knows, nothing here is a surprise. We've known that aging is coming. The problem is it's here. And what I think is different, and I agree with you, is that report focused only on professionals. And there have been subsequent reports, and our report was the first, I think, really to look at the workforce broadly, to really call attention that the workforce is more than the professionals. The workforce is everybody. It's the family caregivers, it's the direct care workers, and really the need for all of them to work together on the interdisciplinary team that I talked about. I found it very interesting in the first panel, the postal worker was mentioned. Some models that have worked very well have included people like that on their teams. The PACE model that many people know about involves the driver, the person that drives the older adult to the care setting, the adult daycare setting every day, because that's the person who knows them and sees them the best. So I think all of those people do need to be working together as a full team.
Yeah, I've been focused, sorry about that, on documenting I will use the term primary caregiver, because in some cases, it's a family caregiver, in some cases, and family in the broadest sense. Sometimes there isn't family and somebody has a paid aide all the time. Maybe it's, a part-time attendant. But the idea of the person who is with the person in need the most and is responsible for providing care. Now, there are things moving in that direction because in the Meaningful Use Program from the Office of the National Coordinator, in their initial recommendations for Stage 3, it does say document members of the care team, including the family caregiver. So it's a beginning step in that direction. And as I mentioned, we're working with others to pull together a meeting to figure out what might be the best ways of doing that. But until we know who's part of the team, and again, I'm thinking of the medical team because I can see all the pushback for what do you want me to document and how much room is there on a record. But that's got to be the first place to acknowledge existence and role.
Thank you. Ms. Rayner, the commission has had a lot of conversation about person-centered care and sort of having that be our focus as we're thinking about our recommendations. And you made a comment in your testimony where I audibly heard a response from the audience as to the training education center's language capabilities. Can you speak to how it was developed and sort of how intentional the foundation was actually to creating this creating those language capabilities as it related to person-centered care?
Yes, I can. So, now I'm on. Red is on. So in Washington State, 25% of the Medicaid home care population today is estimated to speak a language other than English as their primary language today. And so if you are a home care consumer and you are speaking Tagalog, you need a home care worker who also speaks Tagalog. It doesn't work for you to have a home care worker who does not speak Tagalog very well. So, and there's not an infinite supply of people in any region of the country who speak any non-English language. And so Washington State made the decision, in order to preserve consumer choice, person first principle, consumer choice, we needed to figure this language piece out. And the way we figured it out is to simply train people who speak these other languages in their own language so that they can get in the door, have a job as a home care worker with a consumer who needs that home care worker to speak that language. But we don't want to stop there. We also understand that these folks need not only a path to a home care job, but they also need a path throughout the healthcare industry. And so that's the next step, is figuring out how we can build that seamless path for career advancement for home care workers who speak non-English.
Thank you very much. Commissioner Giller, please.
Thank you very much. Ms. Rayner, I have one quick question, and I accept and endorse the value proposition that you spoke about. Now, but my question is one of economics. How much are you free to tell us, how much does it cost to do all that training? Or
I am free to tell you how much it costs.
I don't want to, pry, but.
So our operating budget is about $15 million a year. So if you do the math, that's under $400 per home care worker as an investment in training and workforce development. And if you are familiar with higher ed, cost of training delivery, you understand immediately that that is a really, it's quite a reasonable number.
And the average wage of one of these home care workers is what?
Entry-level wage is $10 an hour, although I have to tell you that in Washington State, we now, for the first time, are seeing an opportunity for these workers to make $15 an hour, which, of course, is the wage that, living wage that people are protesting for all over the country. And so that's an exciting development.
And do they get benefits?
They do. In Washington State, if you're a Medicaid home care worker, you receive, you have the opportunity to receive a health insurance benefit.
Great. Thank you very much. Ms. Harrington, I just have a couple quick questions, if I may. You said that case mix is not audited.
Yes, that's correct.
That's a little different than my experience after 40 years of being in the nursing home industry. You have RAC auditors, you have intermediaries auditing the data. That's not, you don't see that as an audit process?
Well, when the surveyors go out to do their annual surveys, they really don't audit the...
They don't, but someone else does.
Well, the payment, I would venture to say that the payment people don't really audit either. They may look for some outliers, and there certainly are a lot of nursing homes that are reporting extremely high case mix.
Yeah, just a note of interest on this. After having submitted many medical records to justify billing, and I know many nursing homes do that on an ongoing basis, someone's looking at those records because there are appeal processes subsequently. Nonetheless, let me move to another point. You said something about 63% of government funding, and then you linked that to LTSS spending.
Well, I was saying 63% of nursing home expenditures are paid by government.
Supporting
nursing, 63% of
But you include that in and the only reason I asked this is...
And I was saying that overall nursing homes take the biggest share of LTSS spending.
Correct. Now, I ask this question only because there's kind of an internal debate on the commission, or internal discussion, I should say, which is you're including in that number the short-term Medicare expenditure for patients that are in and out of nursing homes within 20 or 30 days.
Yes.
Okay. I just wanted to make sure everyone understood that. On staffing, the staffing levels that you said are recommended by the APS study, right? But CMS never adopted those as standards.
Yes, that's what I'm urging you to say, that we need to adopt these standards, because when you have 70% of the nursing home industry not meeting what is a reasonable level to prevent harm or jeopardy that's been shown in the research, then there's a real problem. And so I think that Congress should go ahead and adopt a minimum standard.
And do you believe therapists are caregivers?
Yes, therapists are certainly important, and they're part of the Medicare payment rate. And yet, nursing homes have very little therapy on average. That's now being reported on the CMS website, and it's less than a few minutes on average per patient. So it's very, very low. It's higher for the Medicare short-term.
Correct.
But when you average it out across the facility, it's like 4 to 6 minutes
Okay, but
per day.
again, I would...
Per resident per day.
Okay, I would respectfully disagree as well. I think that's all my questions. Thank you very much.
This first question is for Ms. Harrington, and I am very interested in the fact that you have said that nursing homes should have a ceiling of no more than 20% of their revenues. Let me read exactly what you said so I don't misquote you. Recommend setting ceilings on profits and administrative costs to no more than 20% of revenues. I'm fascinated, A, with how you decided on 20% and how you would administer that. And I say that from having had an attempt to create some kind of a ceiling for board and care homes when I was managing aging programs in Ohio. And after considerable discussion, consultation with the industry, et cetera, we realized that we didn't, A, know what a reasonable profit was, B, what administrative costs really were versus direct care costs, and found that it was an exceedingly difficult thing to take on in terms of regulation. So I'd be interested in your comment on that.
We completed a study of looking at the data in California on the cost reports, and administrative costs have remained fairly steady, around 16%, but the profits have gone up very high, doubled. And overall, it comes out to an average of about 22%. So it seemed like cutting the combined total down to around 20% would not be it would be a fairly conservative level, and it would be enough to operate sufficiently. So, and I think also the Affordable Care Act set an 80% medical loss ratio for the insurance industry. So I think we were sort of looking at something that would be comparable to that. And we did see that there would be a considerable savings, even with a 2% reduction.
And did you try to tie in quality outcomes at all into this, into what you were setting up here in terms of profits and costs?
What we're finding is that nursing homes, because there are no staffing standards, they're cutting the staffing to keep the profit levels high. And so without having to, if you didn't set staffing standards, if you did put a ceiling on administrative cost and profits, you would have nursing homes would have an incentive to go ahead and spend the money on the care. So that in itself should improve the quality.
My next question is for Ms. Lustig. You were talking about the necessity for more training in geriatric care, and the fact that there has not been, as I understand it, a tremendous response. What are you doing about that, and how do you get folks more interested in that area?
It's very challenging. It's interesting, again, we're looking at this population that's aging, and you would think that most people would say that's a natural career choice because it's something that you're not going to have an limited supply of. There's a lot of reasons why people aren't going into these careers. One of the most interesting ones is when I mentioned financial disincentives. So for a geriatrician, to become a geriatrician, you first become an internal medicine or a family medicine physician. Then you get an extra year of training. The last numbers I saw were that your salary on average is $15,000 a year less than if you had just stayed in internal medicine or a family medicine physician. So it's not only that there are no incentives to go into these careers, there's actually real financial disincentives to go into these careers. So that's a very real thing. And then there's the more intangible, which is just negative stereotypes we even as a nation have of aging and not wanting to go work with what people see as a depressing area. And so we certainly need to do a better job of educating medical students and nursing students and others way earlier on to healthy aging. And that's part of the recommendation for having more training, not in the hospital setting, because in the hospital you're usually seeing people at their worst, they're at their sickest. Whereas if they, some small programs have started having medical students go on home visits, see people when they're in their healthier in their daily lifestyle. And so those are some of the strategies we talked about.
And just very quickly, I want to thank Ms. Mintz for being such a fine a spokesperson for caregivers. And also I appreciate your comments on the volunteer network. I think that's also key.
Thank you.
Thank you. I have a question for Ms. Mintz. Does one need, as one thinks about various programs, does one need a formal process or identification to be a family caregiver? Is it a matter of power of attorney, power of healthcare attorney? Is that sufficient? Or is something more, does the patient, the individual, need to agree to the appointment of a person as a family caregiver? In other words, we're talking all about family caregivers, and we're formalizing it in some way.
Well,
so therefore, one would think, therefore, there needs to be some formality to the designation. And I'm just wondering if you've thought about that.
Well, there certainly isn't any. People become family caregivers because a child is born with CP, somebody has a stroke or is diagnosed with Alzheimer's or whatever. It's a natural process that occurs. If you're talking about guardianship and powers of medical attorney, then of course there are legal papers. There are the HIPAA laws where, somebody says, my wife can have access to my records. But there is no formal way of becoming a family caregiver. It's done because the circumstance is there, and usually because somebody cares about somebody and wants to help them.
I guess my motivation is because if we're designing, let's say one recommendation might be family caregiver needs to be part of the team.
Oh, yes, absolutely.
But family circumstances are sometimes it may be natural, it's the daughter, it's the son, it's the spouse, but it's very complicated family circumstances oftentimes. And I'm just wondering if we're going to get ourselves into some trouble here.
Well, obviously, if the patient is able to make decisions, it is their decision on who they would like to be their family in the biggest sense of the term. And if you were going to formalize by putting somebody on the medical record, the patient would need to agree that this is the person who is providing most of my care. On the other side, on a caregiver's medical record, it should be noted that they are a family caregiver because family caregivers are a population at risk for depression and premature aging and everything that comes with that.
Okay, thank you. I had one other question. I was also quite fascinated by this geriatric finding, the finding that there are no more geriatric physicians over a large period of time. That's a surprising result. One might almost want to sort of dig a little deeper into maybe the designation has changed over time, because, I mean, I'm not a physician, but, I mean, I do observe that most healthcare is provided to older people. So, I mean, Bruce, you're not a geriatric physician, but I'm sure you're very capable of doing that. So I'm grappling with the significance of that statistic.
Practice makes perfect.
And then the broader comment is really a comment, it's not a question, is, over the last few years, I mean, we have seen enormous growth in this field, not just physicians, but, I guess that there must be some attraction to this profession.
Well, maybe I'll just one comment, Mark. I do think that there is a challenge. There has been a challenge in this country attracting physicians in training to the role of geriatrics. And that's an important challenge. And maybe, Tracy, you want to speak to that.
So, I mean, I agree with you in the sense that there are many geriatricians who've received a formal fellowship training and have sat for a qualification exam. And as the 10-year certification comes to an end and they need to recertify, many people are not recertifying, mostly because they don't see what the advantage is of it. It doesn't give them any extra benefit. I would say that geriatrics has not penetrated our sensibility. We all agree that we would take a child to a pediatrician. I don't think that geriatrics has established its value, your added value, as you've said, as well as the field of pediatrics did. But one interesting statistic is that for the fellowships that are available in this country to become a geriatrician, to do that extra training, half of them go unfilled every year. And of the ones that are filled, half are filled by international medical graduates. So there really is a lack of interest in this country because that's one profession where the opportunity for advanced training is available and people actually are not taking it.
So I'm going to wear two hats for a sec. First, on behalf of Carol Raphael, who couldn't be here, she relayed two questions to me based on the written testimony, so I'm going to take this opportunity to ask them. The first to Ms. Lustig, I'd like to ask you to please discuss a bit more the importance of interdisciplinary care team, including individuals, family, caregivers, and direct care workers as key members to provide person and family-centered care. So really maybe speak a little bit more about the care interdisciplinary team.
Sure. And I think we touched on it a bit with the question earlier. But again, it goes back to we have seen in some of the models of care that have been tested out there that interdisciplinary teams are one of the key factors to success. As we mentioned earlier, we haven't traditionally thought of the contributions of the family caregivers, of the direct care workers, of the driver, of the postal worker, of the people that really know and see individuals on a daily basis. And I would go back to the comments I made earlier, which is, though still largely we are among professionals training people in isolation and then throwing them into the real world and expecting them to know how to work with each other, how to talk to each other. There was one very interesting study I remember from our report where interdisciplinary team training happened and everybody loved it and everyone got value out of it. And at the end, they asked who the leader of the team was and everyone said themselves. So obviously we have a lot of work to do. Again, not just the importance of getting those people together, but there are real skills that are needed to work on a team.
Well, let me build on that question for a second. As you guys think about an internet, so this is a Bruce question now, I'm going to mix them up. So do you see the physician as the leader of that team?
We actually didn't talk about that, but I would say not necessarily.
Good, because I agree.
Yeah, quite honestly, it goes back to, I think, what I said early on in my testimony, which is the professionals are really important, but when it comes to long-term care, that's not where the rubber meets the road. It's really the people that are there on a daily basis.
I want to then actually, I'm coming to you next. This is my best Carol Raphael I'm doing here. So if you could maybe speak a little bit more, sort of add on to your previous comments about recognizing the primary caregiver in the role as part of the sort of dyad for service, and specifically maybe speak a little bit to how we might think about documenting family caregivers better in the medical record. Is there something that providers could do today that would be helpful, for example?
Well, it's my understanding that, the format of a medical record can be customized by, any system. And so, yes, there could be a field to designate a family caregiver. But it's not just somebody's name. It's important for the other professionals to know what that caregiver's role is. Are they providing direct care, doing medical procedures? Are they doing care coordination? Are they serving as the advocate? Do they have other responsibilities? And so what fields you create, that's actually going to be some of the kind of stuff that we talk about at our meeting. As far as we know, there isn't any entity that is doing this on a regular basis at all. And so it's really at the beginning of doing it. Now, I know just personally, my husband and I go to the same family doc, and they have an electronic record and a patient portal. I can go in and ask questions or make statements about myself or about my husband and vice versa. They know, that we are a caregiving family. So it certainly can be done if people are thinking about it. But beyond family docs, it's not necessarily a natural medical thought process at this point.
Thank you. Now, two quick questions for me, or two sets of questions. So one to Ms. Rayner. First, let me just say, I know a fair bit about your program because I ran the Department of Health in Los Angeles, and we had a training program that was, I have lots of respect for it, but it is, we really look to what you guys had developed as sort of a model for what great training could look like. I'm really interested in whether you've been able to evaluate that impact of language. I think the language piece is incredibly important, being able to speak to people in their primary language or the family unit in their primary language, because you might have children who are predominantly English-speaking and parents who are predominantly not, for example. It's a tough area, but I'm just wondering if you've or your colleagues in Washington have done any evaluation of the impact of that language, breadth of language, in terms of outcomes or costs. I mean, it's a tough area to evaluate, but I'm just wondering if you have any information about the impact that makes.
Well, I'm not aware of any research studies that have evaluated the impact, but I can tell you that the lived experience of consumers and their families is a very positive one, because the only alternative would be to go to a nursing home where there are no workers who speak Tagalog, for example, or stay at home and have unmet care needs. So the lived experience is one that speaks strongly to the value of training workers in these other languages to make sure that we don't create access barriers.
Then a couple of questions for Ms. Harrington. So what would you say has happened to quality in nursing homes since the passage of OBRA 87?
I would say that in some areas quality has improved, especially in the area of physical restraints, but other areas have not improved. I mean, nursing homes are reporting less on problems on some of their quality measures, but we still see serious deficiencies. We see, so many nursing homes that have been cited for harm or jeopardy to residents, many resident deaths. So I would say we still have a very serious problem in this country, even though we've been working on it since OBRA passed.
So for the record, I mean, I guess I think that there's lots of places in healthcare that are difficult or dangerous, and I think there are lots of places where we do oversight, starting in hospitals and all the way through other sites of care. I actually think that there may be a ways to go, but that there's been substantial improvement in a variety of places. So I just want to be on the record. I think staffing is important in all venues, but this very tight link that you're drawing, I will just say for myself, that's only one dimension of quality, and I actually think that there's been improvement in a variety of areas in skilled nursing facilities. So just that I'm on the record for that. Are you suggesting as well that I thought I heard you say, I want to follow up on a previous question, that there's no oversight of acuity, but my experience is that RAC audits are pretty substantial, and acuity is one of the things that gets looked at. So I'm trying to square those 2 points.
Well, the acuity of measures are taken off the MDS, and they're very complex. And so nursing homes know how to increase their acuity by the way they code. For example, if you code that you have a 2-person assist, meaning that a patient needs 2 people to help with transferring or toileting, you can up your individuals into a much higher drug group. And there's really, I think the oversight tends to be more about whether a resident is making progress and can stay in the Medicare program. It's less on the acuity. There's very little look back to see if those 2-person assist coding is correct.
I'll stop.
Thank you. Thank you all for testifying today, and I appreciate your comments on the workforce and also on quality. Quality being something that's been very important to me over my career. And Dr. Harrington, I had a couple of questions and points for you. You mentioned the quality markers in America's nursing homes and how they may have improved, not improved. There was a quality initiative launched about 2 years ago that focused on 4 areas, which was readmissions to hospitals, off-label antipsychotics, staff turnover, as you all have focused on here today, and customer satisfaction. We have reported back in 2 of those areas, and I'd like to note that these areas are also areas that were supported by CMS and the Advancing Excellence campaigns and the QIOs and various initiatives. We've showed readmissions have decreased by 2.2%, while our use of off-label antipsychotics have decreased by 9% in a very short period of time. To me, that is improvement in quality. Further indicators are whether I see some people in the room who sat in the room with me and with CMS when we were developing the 5-star system. And although it's not a perfect system, some of us decided that we tried to make it better over time instead of necessarily being against it. That system, since its inception, we've seen 5-star facilities increase from 11.6% to 19.5%. We've seen 4 stars increase 23.5% to 27%, and 1 stars decrease from 22.3% to 13.4% by CMS's own measures. While I like that system in some regards and don't like it in others, I would like to, first, before I get to my final question for you, and I'm running out of time, I shouldn't be Southern, I talk too slow, is the system counts LPNs the same as CNAs unless they're in administrative nursing. How do we recognize, and when we're going to, and my question will be to Dr. Lustig, how do we get to the point where we value LPNs? Would you consider them closer to RNs, closer to CNAs in their skill sets, or somewhere in between?
Boy, I'm going to get in trouble with the nursing community if I made a judgment like that. I think how we get closer there is it's kind of, not to reiterate, but it's really, again, about that team. One thing I was thinking about, again, was we talk about direct care workers or nursing aides or LPNs, and one of the challenges I think we have is terminology is there's lots of titles, and they are overlapping in what they do and what their qualifications are, and so it does get tricky that way. But I think what we need to go back to recognizing is all of those people, whoever touches that individual, is part of a team. And we need to recognize that all of them are contributing something and all of them need to be valued. When we talk about the turnover rates, one thing I was thinking about I failed to mention was just including direct care workers in decision-making really increases their job satisfaction and decreases turnover. It's such a simple thing. But even just asking the opinion of that person could really go a long way.
Well, thank you. And, I'm hopeful that CMS will do some work in that area. And so if you accept that, we do need to get more refined on how we count staffing and looking at quality, and Dr. Harrington, this question is to you. If you accept that there aren't more resources, how do you feel about really concentrating on poor-performing nursing homes in the regulatory process by maybe being less burdensome on those that are high performers with higher outcomes and higher quality measures? Have you looked at any research or have any thoughts in those regards?
Well, I think, nursing home quality varies a lot, and it can change rather dramatically. If you have a change in the director of nursing or the administrator, the the care can change overnight. So I think having a minimum of an annual survey is absolutely essential, and I would like to see the surveys more frequent. There is a process when they do, in the survey process, they pick the sample, and there is a two-step process, so they can do a more in-depth analysis for those facilities that show quality problems. So there is already somewhat of a system like that built into the survey process.
And just one quick final question. When you were talking about the margin analysis and administrative costs, were you looking at allowable cost or total administrative cost?
We're looking at total administrative costs because we looked at total costs, administrative costs across, some are not allowable, but that doesn't really mean that they don't get to keep the money.
Okay.
It just means it doesn't go into the rate.
Okay, thank you.
So, Tracy, I wanted to ask you to start with you, and thank you for your testimony and comment on the recommendations that the Institute of Medicine made in 2008. I wondered, when making those recommendations, we hear questions about whether better training, better wages, greater requirements, what that will do to costs, and I wonder whether those kinds of issues arose when you did your report, when the committee addressed the issue and made its recommendations.
So a bit of a cop-out, which is that our statement of task didn't require us to examine the financial implications of our recommendations. I will say, though, that the committee certainly remained aware of financial realities and didn't recommend things that we thought were so ridiculous that wouldn't happen.
Oh, okay, and we heard some testimony on the $400 a person for training for what sounds like good training it does not seem in any way beyond the pale. I'm also interested that you made the recommendations for the list that I described. It sounds as though in 2008 they sounded very general, that wages should improve, training should improve, whereas I think Carissa and Charlene were making very specific suggestions about the federal government should require, the payment system should include, and I wonder, in terms of when all of you are thinking about recommendations that this commission might make, do you think it advances the field much if we say quality should be improved, wages should be reasonable, or do you think we need to put a little muscle here? Comments, anybody?
I think general recommendations are like mom and apple pie. It seems to me the whole purpose of this commission is to get down to where the rubber meets the road and make some real, obviously difficult recommendations, but ones that look at all the factors and that can be implemented. But, we've all been talking about this for so long. We all know what the the problems are. Let's put some actual decisions and changes in place.
Yeah, I'd like to speak to that. As someone who served on the Institute of Medicine Committee for the Nursing Home Reform Bill, that Institute of Medicine Committee report was extremely detailed, and Congress adopted it almost wholesale. I think you need to have very specific recommendations.
If I can add, some of our
Please do.
recommendations were very general. In the case of increasing wages for direct care workers, what we found was we just didn't have a strong enough evidence base to say exactly what was the one right way to do it. We talked about lots of different options, but we just didn't have the evidence level to say this is the way it should be done, which I'm sure will be a challenge for you as well. But I did sort of gloss over some of the recommendations here a bit. For example, our recommendation to increase training for direct care workers, which hasn't changed from 75 hours, we did recommend 120 hours as the specific number. We based that on we looked at what every state requires, because many states go above that, and the top quartile were 120 or more. And so our reasoning was, if the top quartile can do it,
Right, and you're appropriately addressing the standard, what it is that a minimum standard would be, and so you're saying you did recommend a minimum standard, and I would go beyond that. I think that Carissa went to say that it should be the federally established minimum standard. Am I correct? Yeah.
All right, it would head off the problem that Washington State experienced, right? So if we have a federal minimum training standard for home care workers that at least approximates that for workers in nursing homes who are really their peers, then that will go a long way in creating some, just more ease as the states transition into home and community-based environments.
Okay. Thanks. And I just wanted to say, Charlene, with respect to the issue that's come up about coding and case mix, I think that MedPAC supports your concern that you've raised about upcoding as being a big issue in the post-acute care field, and that is something that not only independent of the payment of the limits that you talked about on profits or administrative costs, that there are proposals for payment reform, including some of my own and related to shared savings, that can promote the investment of resources in actual care and do something about the very high profit levels of post-acute care providers.
Commissioner Turner.
Thank you all very much. Dr. Harrington, your testimony, just a personal comment of mine, it makes me understand why some people may be worried and maybe even frightened about going to nursing homes. It sounds like a pretty scary place, and I think that I have to question whether or not it really is quite as bad as you report, because I think we'd see families and caregivers just marching in the streets. But a specific question for you about your slide number 15. You talk about the percentage of profit for for-profits and nonprofits, and I'm wondering, first of all, an observation, the percentage profit for nonprofits, not an inconsistency in terms, has been about 600% over the 6 years that you report in your chart, whereas the percentage of profit increase for for-profits has been less than 50%. But I'm wondering if you calculated in the fact that the for-profits also have to pay taxes out of their percentage of administrative costs and profits, which certainly reduces that amount because that money has to go back to the government and state and federal governments.
Oh, when these analysis exclude taxes, they're not put into the administrative costs.
Because most of the time, the profits have to, the taxes have to be paid out of that amount that is not going directly to care.
Mm-hmm.
Well, you've subtracted that first differentially for the for-profits and the nonprofits?
Yeah, we did look at the profit margins, and I mean the tax issue,
yeah.
and it's fairly small. But yes, that would be a difference between the for-profit and the nonprofit, definitely.
Mrs. Mintz, thank you for your personal stories that you have really shared with us about the challenges and your lifelong challenges nearly of providing care. I'm interested in your perspective on training, formal training for family caregivers, and if that's something that you think is possible. Is it possible to develop standards? Your advice for what the commission might be able to recommend around that.
I think that it can be very tricky if you start thinking about certifying family caregivers or anything of that nature. People need training depending upon the basic circumstances that they are living with. If somebody's dealing with Alzheimer's, it's very different than if somebody's dealing with somebody with a spinal cord injury, but who can participate in their care. And so that's part of where the idea of the identification comes in as part of the care team, because the kind of training that somebody needs is relevant to the circumstances that they're in, and they would change over time if somebody's disability gets worse or something like that. So yes, family caregivers need training, and there now is the model that the VA has set up, but it's so individual, and I see it as part of the ongoing process. Learn what you need to know when you need to know it. There's no point in giving people a whole lot of information because it might be important down the road. What I do think is important is to teach people how to fish so that they can develop some skills on their own. I think it's important that both physicians and family caregivers and patients learn how to communicate better with each other, because that would go a long way to resolving certain problems. I think it's important for family caregivers to know what's the best way to report symptoms, so that they're giving information in a way that makes sense for the professionals.
Thank you very much. I have only just a couple of seconds left, and I'd like to ask questions to Dr. Lustig. You talked about the importance of the team approach, and I only have a very quick response. We're always interested in the policy recommendations you might have, and anything in particular that's in the way of developing that kind of team approach now that you might suggest to us as far as recommendations are concerned.
Certainly, there's always opportunities. There have been lots of interdisciplinary team training programs. Geriatric interdisciplinary team training programs have been happening for decades, and some more can be done to fund those types of programs. And then certainly a larger issue that I don't have a simple answer for is just the time it takes to coordinate and talk to teams and meet just is a non-reimbursable event. And so people have to value it and do it. That would be my short answer.
Thank you very much.
Thank you all again. One of the things that strikes me is the comment, I think it was Tracy Lustig, that mentioned about people not going into geriatrics. And I went into the work I'm doing because of my incredible relationship with my grandfather. And I think that one of the things we need to do is not live in silos. The more we can have people living with people with different functions and different ages. I gathered that Facebook there was some study, and the perception of older people by people on Facebook is really appalling. And anyway, it's just a comment. I think I'm among them, and I'm on Facebook, But anyway, we need intergenerational everything so that people are not afraid or to deal with one another. if you could, Carissa Rayner, if you could help me, what do you think, if there's one or two things that would be the most likely to bring people into the direct care force, what would you want to, if you could say to us, at least do this, Commission, ensure this or that?
Well, three things come to mind. First is wages. Wages have to advance if the work is going to be competitive. When you look at workforce supply, native-born workforce supply in this country, the growth is flat over the next 40 years compared to the previous 40 years. That means everybody's going to be vying for the same workforce in ways that they're not today, and we can't be complacent about wages. Second is training. Training is critical if people are going to feel comfortable and prepared in going into this work. Third is career advancement opportunity. Training sets the foundation for career advancement opportunity. Those, if I had to pick, I would say are the three key areas, structural areas that this commission could look at to help advance the competitive nature of this workforce. And
can that be done by incentives, encouraging, or do you think it needs to be required?
Well, I can tell you, just to take for one example, training. If you look across the country, voluntary training programs for home care workers have very low uptake. So then you pan to Washington State, where it's a requirement, it has very high uptake. So if we want people to embrace these different advancement areas, I think that we have to get serious about it and not leave it up to the direction of the wind and how it's going to blow.
Thank you. I appreciate the help. Ms. Mintz, I've followed your work and I regard what you do. I also, in some ways, feel, maybe I shouldn't say that, but my mother helped take care of my stepfather at Huntington's disease. And I remember one time we were sitting around the room applauding the direct care worker that we had finally convinced her to have. And she didn't want anybody in the house. And my stepfather could hardly speak. And we were thinking Rose or this one was doing just great. All of a sudden we heard from the room with the greatest of effort, bullshit. And the fact was my stepfather did not like that woman at all. That's why he would for a while be able to just, I wondered what the brain process, it was so helpful. So what kind of direct care help do you and your husband need? I also work with a lot of people with multiple sclerosis, and I've had in my family. And what would be the one or few best things that the non-volunteer system could do to help you?
Well, I mean, I agree with everything that was just said about what's needed.
Okay.
But we also have to look at the other side of the coin, that it's already expensive for people to have attendants or home care aides because it's all out of pocket. So we need to look at the corollary of how do we improve the direct care workforce and how do we make it
not out of pocket, perhaps.
Well, that gets to the idea of a certain number of hours or some
So that's part of
mechanism.
what I'm asking you. So is that a gap that you find?
Well, yes, of course, because I think the number is 42% of caregivers have some paid help, but it's a question of whether you can afford it, quite frankly. I think there's another point that I want to make, and that is sometimes people need non-medical services, but they also need, quote unquote, nursing services, and they can't be provided by the same person in the current setup. And that doesn't necessarily make any sense. And so this idea of an advanced aid, I think, is important so that we can meet the real-life needs of people.
Thank you. And call me about Medicare's home care benefit.
Well, thank you again for being such an informative panel, and I am the thing that stands between you and the end of the day. So let's see if I can make this painless for you. I think, Carissa Rayner, I'd like to direct the bulk of these questions probably to you, but there may be some that the other panelists want to jump in on. So in Washington State and the training protocol that you provide for home care workers, can you talk a little bit about how you deal with the dynamic of consumer direction and allowing the individual to be empowered and making decisions and choices and the balance you have to make there?
Absolutely. So I'm glad you asked this question because it's critically important as other states are thinking about how they address this issue. So in Washington, this is how we address it. A, we have consumers at the table to help inform the development of the curriculum itself. B, we feature consumers as instructors or in our online training. We feature them there. 3, we make sure that we include in the content of the training person-first principles throughout. So what this means for you as a home care worker is that you are trained in a core skill set, say transfers, but then you're also trained, very importantly, on how to solicit from the consumer how that consumer wants to be transferred. So you hear sometimes this in discussion. Well, home care workers, should they have formal training? Consumers are providing training. Yes, both. So they need formal training to develop a core skill set, and then, like all jobs, they need on-the-job orientation in order to understand how to apply that core skill set to meet the consumer's unique needs.
And I just note for the record that what Ms. Rayner has offered up is significantly different from what one might receive through a certified nurse's aide training course. And next, back to you. Could you tell us a little about how you treat the diverse populations that a worker may encounter? For example, there are people with intellectual and developmental disabilities, and does your curricula address that kind of specific population among the diverse needs that a consumer might present?
Yes, absolutely. So our curriculum is designed with a core set of skills that work across all populations. And then on top of that, you have special population content. So developmental and intellectual disabilities, physical disabilities, which includes spinal cord injury, traumatic brain injury, dementia, and then mental illness. So those are the 4 special populations on top of the core. And you as the worker with your consumer or employer, if that makes sense, then select from that menu which you mix and match, or you select and go deep in one area to supplement your core. So in that way, you are building skills that have cross-population applicability, but also skill that's very specific to the person that you're supporting. And then you have annual continuing education. So you can go back, right? If you have a different consumer at some point, or your consumer develops different needs at some point, you can go back and you can continue to develop your skill set.
Thank you. Last question, and I'd open it up to the panel. It's a fairly specific question based on infrastructure that might or might not be available to help individuals that need personal assistance services find and identify individuals that they might hire to do the work. And in Washington State, there may be some infrastructure that exists, but maybe I should allow you to answer the question and hear from other panelists if they're knowledgeable of this infrastructure.
Well, I'm glad you raised this too, because this is another critical point. How does demand find supply? And Washington State, there is a registry service that is administered by the state. It has had, I would say, and I think they would agree, modest success in achieving that matchmaking goal. But I also want to offer up that there are other models for matchmaking that exist and that we could build off of. So I think that there's some encouragement there.
And in closing, I just look for some insight into, are there mechanisms that we should be thinking about to help individuals that are hiring direct care workers are there mechanisms that will help them comply with their FLSA and IRS responsibilities and address kind of the gray market where people are paid and perhaps sometimes under the table? There are laws about hiring people and paying appropriate wages. And is there any wisdom on the panel that might you offer up?
Well, some states have established health authorities or mechanisms so that they can handle all the payments for personal care workers, and we think that's a good way to go. But unfortunately, that's mostly limited to Medicaid. So we would like, I would like to recommend that you recommend registries throughout the country, but also that could be used not only by Medicaid, but by any person who needed a registry, and that there would be help, there would be some kind of system in each state so that payments could be made through a fiscal intermediary or health authority or something.
Thank you.
With that, I want to thank this panel very much for their presentations. And with that, I also want to say, on behalf of the Commission, we thank all the previous panels who provided public testimony. With this panel, this concludes our public testimony phase of our work. We appreciate all the input we've received. We also appreciate the input we've received through our website. The Commission will now work hard to think through the information that we've received. 3 months is a very short time to tackle a problem that many of you have spent a lifetime on, so I'll just point that out to all of you, and we look forward to reporting out at the end of next month. Thank you very much.